Okay.
There was some baby who is in our unit who is known to your forgot her name.
Okay.
അവരുടെ
Her name was Kashmira, I think. Kashmira.
Yeah, Kashmir is a consultant at our place.
Yeah, yeah. I think she knows one of the babies who is admitted to our unit.
Okay. Fine, fine. I think I dropped a message on the group also for the delegates to join. And I think we'll start in next 2-3 minutes. તો અનુજભાઈ બીજી નવા જોડી
બસ હવે આપણે મળવાના જ છીએ બાકી તો અહીંયા તો રૂટીન ચાલે છે.
Yes, yes, yes. Basically, Gujneocon is mainly to get together all the neonatologists of at least Gujarat.
Yeah, I think it's a good thing that we can at least meet up once a year.
Yeah, and we always encourage newer people also, the residents and the fellows and the junior fellows to come for these meets so that they understand that what is the practice in our state, in different cities, kon kevu kare che, how to set up a practice. Because we always talk about academics, we always talk about lectures, about ventilation and badhu, but we never talk about management, we never talk about teamwork, how to establish a unit.
That is actually more important, I think. Management તો ચોપડી વાંચીને આવડી જાય.
Yeah, when we meet different people, you understand that how they have set up their unit, how are they running the unit, and what are the intricacies in setting up a unit and running the unit for a long period of time. So this becomes very important. મને એવું લાગે કે from next time we will do a workshop on hospital management.
Absolutely. How to set up an NICU.
Yeah, how to
How to
manage an
set up and run the NICU, yeah.
Yeah, because setup bhi કરી નાખે છે બધા, but then how to run the unit in a proper way so that it sustains for a long period of time. That is important.
I think team working is absolutely crucial there.
Yeah, teamwork and ત્યાં આગળ IQ કરતા EQ is more important. So how you manage your whole team along with the doctors and all the paramedical stuff, that becomes a very crucial part.
Is your unit close to the venue?
Surat as such is not a very big town in terms of place. So from here to the venue would be about 20 minutes.
20 minutes. Okay.
I think we'll start, Anujbhai, because it's almost 7:10. It's late time.
Absolutely.
So first of all, on behalf of our West Zone Gujneocon conference team, I would like to welcome all the delegates and all the faculties for the second day on the online ventilation workshop schedule. Dr. Ashish Bhai is the main director of the program and he will be joining soon. So yesterday we had a very a nice detailed discussion about the topics, and today again we have lined up very interesting and very practical talks today. So I want every one of you to listen to the talk properly. Whatever questions you have, you can put up in the chat box, and we'll try to cover up the questions at the end of the talk of the expert. So first of all, if I can get a photo of everyone, you can just put on your videos, everyone. You get all your videos, then we can just take a photo. Everyone, still. I would request everyone to put your videos on for a one picture, if it is possible for you. Smile, everyone. Okay, thank you very much. So today, it gives me great pleasure in inviting Dr. Anuj. As you would be aware, Anuj is a chief neonatologist at Setu Children Hospital at Ahmedabad. He runs a big neonatal ICU there with his team of other two doctors. And he has a lot of work on ICU. He has a lot of publications. He's one of the important faculties at all national conferences. And uh, today I would invite Anuj to give a talk on pulmonary graphics, which is a very interesting topic. And you can learn a lot of things from the graph also. So, Dr. Anuj, welcome. You can start your screen.
Okay. Good evening, everyone. Thank you very much, Sachin Bhai, for the kind introduction. Thanks to Dr. Ashish sir, Mohit, and the entire organizing team of the Gujneocon for inviting me for today's session. Uh, you've already done a lot of sessions in terms of basic ventilation yesterday, and today we'll build on from there. And I'm going to talk about pulmonary graphics. I'll just start sharing my screen. Is that visible to everyone?
Yeah, this is visible.
And the changes are happening here? Slide changes?
No, we are just on your first slide.
Okay, okay.
Yeah, this is okay.
But it's still the first slide or?
This is the third slide, monitoring of a ventilated baby. Now
Okay.
you're on the first one.
Okay, gone. The slide changes happened?
No, this is still the first. You can put the slideshow on.
Yeah, I did try the slideshow. I'll just close it and open it.
Yeah.
Okay.
Is it now changing?
Yeah, this is fine. It is okay. You're audible and your screen is also changing.
Thank you. Okay, so the objectives of today's session, firstly, is to identify the different graphical display options provided by the mechanical ventilators. And we're going to learn how to use these graphics to adjust the ventilator settings, avoid the problems that the baby might have, and get a better outcome. So you've already learned how to initiate the ventilation, okay? But monitoring of a ventilated baby, now that you've already initiated the ventilation, your goal is to extubate the baby. The aim of every intubation is extubation. Okay, so but we need to monitor the baby carefully. And these are 4 ways we can monitor the baby. The first is looking at the clinical profile of the baby, so the vitals, the saturations. The second is using blood gases, whether arterial or capillary gases. The third is using X-rays or ultrasound. And fourth is the pulmonary graphics. So clinical profile and pulmonary graphics are the only 2 real-time information providers. The blood gas and the X-rays you can't be doing every few hours or so. You can't be doing every 2 hours or 1 hour. So, but you constantly looking at the clinical profile of the baby and looking at the pulmonary graphics as to see how the lungs are behaving, what is the lung compliance, the resistance in the circuits, and that's how you can fine tune the ventilation and so as to achieve a successful extubation as soon as possible. So the pulmonary graphics are just the graphical display of curves and loops during a mechanical ventilation, and it is to determine how the patient is being ventilated and to assess the problems occurring during the ventilation. So the ventilator, if you understand, there are some things that the ventilator measures, some parameters that the ventilator calculates based on what is measured. Okay, so the flow, the pressure, and the time are measured, and from that information, the ventilator then calculates the volume, the compliance, and the resistance. And all these values and then are displayed in a graphical information, and that's exactly what is pulmonary graphics. So the three measured parameters that you can see, the flow, pressure, and time, if you display them in as curves, they are your scalars, and the volume and the compliance, those are part of your loops. So what is measured where? So the pressure is measured at the machine end, the time is measured at the machine end, the flow is measured at the patient end with the flow sensor in place. Okay. Based on the flow, the volumes are then calculated using a algorithm. So we all have seen flow sensors in their workplaces. So when you connect the ventilator to the flow sensor and the flow is going through that, there are 2 platinum wires inside the flow sensors. Now those are heated to 400 degrees. There is a constant current needed to keep keep them at that degree of temperature. But when the gas flows, these wires that cool down, and because of the cooling, there is another extra current that is necessary to maintain that temperature. So based on the calculation of the current, we can calculate the flow, and from the flow, we can calculate the volume of the gas. Okay, it's very fast, very sensitive, very accurate, and very widely used these days. I mean, 20, 30 years ago, we were not using any of the flow sensors, but these days, modern ventilation, you ought to use the flow sensors. But what do what do these flow, pressure, and volume graphs tell us? Firstly, you can confirm what mode it is the ventilator on. You can detect the equipment malfunctions. You can decide whether the appropriate PEEP level is there or not. Evaluate the adequacy of inspiratory time. Detect the presence and rate of leaks around the tube. Auto PEEP. Whether there is asynchrony between the patients. You can look at the trigger levels. Is the baby triggering appropriately, and then adjust the trigger levels. You can measure the work of breathing, adjust the tidal volume, avoid overdistension, and even assess the effect of bronchodilator administration. We will look at all the graphs and loops in more details now. So there are basically 2 types of pulmonary graphics. One is called the waves and the scalars. And there are 3 types of scalars: flow time, pressure time, volume time. These are the 3 different scalars. So the pressure waveform on the top, the flow waveform, and then the volume waveform. And there are 2 types of loops which we use. One is called the pressure volume loop, and the other is the flow volume loop. So this is what the loops are looking like. So this is the pressure volume loop, and this is the flow volume loop. Now let's look at each of them in a little bit more detail. So the flow time So when you have a baby breathing, so in the spontaneous breath, the inspiratory flow begins, and at the end of the inspiration, there's an expiratory flow, and then that slowly goes back to the baseline, and then the next inspiration starts. This is how a spontaneous breath looks on the flow versus the time. So the time is on the x-axis and the flow is on the y-axis. A mechanical breath looks more like this. So you have an inspiratory phase where the flow goes up, and at the set inspiratory time, there's expiration starting, the flow goes down, the backward flow, and then the expiration happens. There are four types of flow patterns. One is the square wave, the second is the decelerating wave, accelerating wave, and the sine wave. Depending on which mode you are using, your waveform of the flow will change. But generally, in newborn babies, when we're using the time cycle pressure limited ventilation, it's the decelerating flow pattern that you usually see. Okay, but what do they look like in the so when you have the closure of the exhalation valve, remember in the physics of mechanical ventilation you would have learned yesterday, it's basically when the exhalation valve closes, the flow begins towards the patient, and that starts the inspiration. It reaches the peak inspiratory flow rate, and after a set I time, the exhalation valve opens, and as the exhalation valve opens, the flow goes the other way, and so that is the inspiratory time. Once the flow goes down, it reaches here the peak expiratory flow rate, and then it goes back to the zero. This is your expiratory time, inspiratory time, and the total cycle time. Okay, this is how the flow pattern usually looks. Now, the flow wave or the flow scalar, what is it used for? Where can you use it in the clinical practice? One is to optimize the inspiratory time. Second is to look for airway obstruction, evidence of gas trapping, leaks around the tube, and the airway resistance. So let's look at a few examples. So in this example, you can see, so the flow went up, the inspiration has the inspiratory flow here has reduced, but the exhalation hasn't started. So there is a kind of a pause, which is called the inspiratory pause. So the baby is kind of taken a breath, but is not able to exhale out. The inspiration has ended, but the exhalation has not started. So this is a wasted time, and the baby is going to not really like it. So you want to avoid that inspiratory power pause. So this is because you've set inspiratory time too long. So what you need to do is reduce the inspiratory time so that there is no pause like this. If you have going back to other side, so if you have insufficient inspiratory time, so if you have a flow like this, and before the flow could return to zero, the exhalation valve opens, and you have a short inspiratory time. So you need, if you see a pattern like this, you need to increase the inspiratory time. You can also have insufficient expiratory time. So in this case, what you're seeing is at the end of the expiration, the flow does not reach zero here. The flow does not reach zero, you're going to have gas trapping, or called auto PEEP, and then the baby is going to run into problems. So what you need to do is increase the expiratory time or lower the rates in this case. Okay. You can also see the increased airway resistance. So normally the pattern in the expiration would be like this, but if it's prolonged expiration, so if there is something that is causing, say, like a bronchoconstriction, that is going to reduce, so that is going to increase your expiratory time here. The slope is more shallow. Now the flow wave is also useful when you're setting the triggers. So this is an example where you can see this baby is on PTV mode, but the trigger is set too high at 2 liters per minute, but the baby is not able to generate those flows on its efforts. So each of the effort is not really getting the support. Okay. Once you reduce the trigger here, So you reduced it to 0.7. Now the baby is able to trigger the breath. So now the ventilator is supporting the breath. So go back, see the pressure or the tidal volume generated here are very poor. Okay, but here the tidal volumes are generated are much better because now each of the baby's breath effort is being supported appropriately. The second waveform that we're going to talk about is the volume versus time. So in the volume versus time, the volume is on the y-axis and time is on the x-axis. So in the inspiratory time, your as the flow begins, the lungs begin to fill up with the volume, and at this set I time, the expiration starts and the lung volume starts to go down. So, okay. Where is the volume scalar used? So it can look at the leaks and adequacy of tidal volume particularly if you're not using a volume targeted modes, and it also can tell you accidental extubation. So how do you judge adequacy of tidal volume? Say you have set a particular tidal volume in a volume targeted mode. If you're not able to achieve those targets, so if the volume is less, then the ventilator is going to ask you to increase the pressure. But if you're not in a volume targeted mode, that is something that you will have to do. You have to monitor the tidal volumes that you're achieving, and if your tidal volumes are less than what is desirable, you should increase the pressure. But if your tidal volumes are higher, then you're risking volume trauma or over distension. Then you should lower the peak inspiratory pressure. How will the leak look like? So your inspiratory tidal volume goes up. At the end of expiration, the volume does not reach to the baseline. So there is a leak of a few ml that you can judge from this. So where has that air gone? So either that air has leaked around the tube, or there is an air trapping, like say in a ball valve mechanism in a meconium baby. Okay, so whatever is the inspiratory volume, the expiratory volume is less than that. That's what the flow sensor is telling you. So that volume has gone somewhere. Most likely it is leak around the tube. So if the leak is very high, say more than 25-30%, then the volume targeting mode can be difficult to use. So then you might think about using a bigger size tube. The accidental extubation. So here you have an inspiratory volume loop, but you don't see any expiratory loop. So the flow is going from the ET tube towards maybe the esophagus, but there's nothing going to come back, so you're not seeing any of the expiration. So that suggests that the baby's tube is not in the right place. It's probably displaced in the esophagus. Okay. Third waveform that we tend to use is the pressure versus the time. So in the pressure versus time, so the pressure is on the y-axis and time is on the x-axis. Here, at the start of the inspiration, the pressure starts to build up, it reaches a peak inspiratory pressure, and after a plateau phase, it will go down to expiration and go back to the PEEP level. So this is a level that you have already set the PEEP. So there's a peak inspiratory pressure and positive end expiratory pressure. Okay, this is how a mechanical breath looks like. We'll see the spontaneous breath and the triggered breath as well. So where does the pressure waveform help you? So it can look at the integrity of the ventilator in the circuit. So as long as you're able to see a good pressure waveform, that means the ventilator is delivering the pressure. But if the volume waveform and the flow waveforms are not good, that means there is a problem from the baby side, or there is some leak or so. But so ventilator integrity and the circuit integrity, the pressure waveform will tell you that. You can also look at the adequacy of the flow, and if you're having problems with oxygenation, the factors affecting the mean airway pressure, you can have a judgment of that through the pressure waveform. How does the pressure waveform look in a spontaneous breath? So there is a negative deflection, okay, because the baby takes an inspiration, and at the end of then the baby expires. There's a positive deflection, which is reverse of the control breath. In the control breath, there's a positive flow towards the baby in the mechanical breath and away from the baby in the expiration. What about an assisted breath? In assisted breath, the baby starts to take a breath. There's a negative deflection, but the ventilator now supports this breath and the pressure goes up. And after the end of the inspiratory time, the pressure goes back to the baseline. So that is a patient triggered breath. So that's how you can differentiate between a assisted versus a controlled or a ventilator given breath. And the spontaneous, which is not supported by the babies by the ventilator, your peak inspiratory pressure will be much lower. So this is how a spontaneous breath looks like and a mechanical breath looks like. But when you have inadequate respiratory flow, so instead of these flow being looking like a convex, this looks like a concave. So there is a scooping out of the flow. So if there's a inadequate flow, so that means you need to increase your flow. So most of the ventilators these days, actually the flow is adjusted by the ventilator. So you probably don't need to do, but Draeger 8000 and even the VN500 have knobs for adjustment of the flow. I'm sure this diagram you've seen in some of the lectures yesterday, where you're looking at how to improve the oxygenation. So the oxygenation is governed by the mean airway pressure. How do you increase the mean airway pressure? So either by increasing the PIP, increasing the PEEP, increasing the inspiratory time, increasing the flow to a square wave, and reducing the expiratory time. So all these measures can increase the area under the curve and the main evaporation. That will help improve your oxygenation. We're coming to the two loops. So the first of the loop is the pressure volume loop. So this is one of the most important ones to look at. So here you have volume on the y-axis and pressure on the x-axis. So during the inspiration, this is how the hysteresis looks like. So the volume goes up with the pressure, increase in pressure, the volume goes up, and during expiration, it forms a loop. So it doesn't go up and come down along the straight line. It kind of forms a loop like this. Okay, so this is your maximum PIP, and this is the tidal volume that has been achieved. Again, in this, you can differentiate how a controlled breath looks like versus assisted and spontaneous. So let's look at that. So this is a controlled breath, similar to what we've just described previously. In the assisted breath, you will see a negative deflection in the pressure. So once you see a negative deflection, and then the ventilator supports it, and this goes back to this way. But in the spontaneous breath, there is also, supposing you put the baby on ventilator or CPAP, there's an inspiration breath here, and the expiration is on the positive side now. So this is how a spontaneous breath, which is unsupported by the ventilator, will look like on the PV loop. What are the uses of PV loop? So PV loop shows you the change in the compliance. So this is one of the most common things that you need to look at, and most important ones to look at is over distension, the leaks, inadequate flow, whether there's increasing resistance. It also tells you how you can see the use the optimum opening pressure or the optimum PEEP for this baby. So the hysteresis in the flat loop where there's a low compliant lung, say example, a premature baby with hyaline membrane disease, RDS. This is how the flat loop will look like, so low compliant lung. Some people also claim the penguin is sleeping kind of thing. But as the compliance improves, the loop becomes upright. So for the same pressure, you're getting much higher volumes. So with good compliant lungs, your volume improves even at lower pressures. So the penguin kind of stands up with upright loop. So let's look at that in a little bit more detail. So here you have a baby on pressure targeted ventilation. You have a preset PIP. This is a baby with RDS, and you're achieving very low tidal volumes. Now that you give the surfactant, what happens is your tidal volumes improve. Okay, so for the same PIP, your tidal volumes are higher. Okay, but if you don't do anything, the tidal volumes are going to go even higher. So you run the risk of over distension and causing volume trauma. So as this loop rises up, for the same pressure, you are getting higher tidal volume. So that's what we need to be wary about. Kind of think of reducing the pressure. Once your tidal volumes are better, reduce the pressure. Okay, so you don't want to exceed that tidal volume here. If you have it on volume targeted mode, what here you have set a preset tidal volume. Okay, initially when your baby has RDS, you are needing higher pressures to achieve the same the desired tidal volume. Once you've given the surfactant and the compliance improves, you're going to need lower pressures. But if you have on a volume targeted mode, the ventilator will automatically reduce the PIPs. Okay, so as the compliance improves, the in the volume targeted ventilation, this PV loop is not going to rise up, it is going to shift to the left. Okay, so this is an important thing that you need to remember. So here is a normal lung, but if you, as the compliance improves, you can get this shape which is called the beaking or over distension. So for that rise in the PIP, you are not getting much of tidal volume rise. Very little change in the tidal volume, even though you have increased the PIP. So that is over distension or beaking. So if you see that kind of a pattern, the first thing you should try and do is reduce the PIP or go for a volume targeted mode. There's another way of measuring the beaking or the over distension called the C20 by C ratio. So here you have something called the lower inflection point and upper inflection point where the loop changes. So now beyond this upper inflection point, there is beaking. Okay. So the last 20% of this compliance loop compared to the whole of the compliance, that's what is the ratio C20 versus the whole of C. So ideally, this ratio should be 1. So the compliance should be uniform throughout your inspiration phase. But if your compliance is low, if you're getting beaking, I think there's somebody's.
Okay, sorry.
Sorry, if you have beaking, this ratio C20 to C is less than 0.8. So again, if you're seeing your ventilators usually display this ratio. If you're seeing ratio less than 0.8, you're running the risk of over distension beaking. So you need to come down on the pressures. Okay, so when you have a zone of, this is a zone of over distension, and if your loops are running in this area, so that is a zone of atelectasis. So this is the area that you should be having the loops in, which is called the safe zone, avoiding the atelectotrauma and the volute trauma. So when you add PEEP to the PV loop, so the loop kind of shifts a little bit to the right. So the pressure, this is the baseline pressure that you're starting at. So if your PEEP is inadequate, the loop doesn't rise much. So your lower inflection point is much uh, towards the right. So in this case, if the PEEP is set at 2 to 3, you need to keep the PEEP around 5 or 6 so that you get this kind of a graph. If you kept the sensitivity inadequately, the baby has to work harder. So the negative inflection point goes even more towards the left. Okay, so the more it is towards the left, that means the baby has to work harder to trigger the breath. So make sure you don't, that this is not going too much towards the left. How will the air trapping or air leak look? So you have as the pressure goes up, the volume goes up, but during the expiration, there is the volume does not go back to the baseline. So there is a leak or the air trapping effect that you can see on this PV loop as well. You can also look for resistance. So normal graph would be like this and expiration here. But if your inspiratory bit is thickened, that suggests increased inspiratory resistance. And if the expiratory limb is thickened, that suggests increased expiratory resistance. So increased expiratory resistance typically with bronchoconstriction or secretions. Inspiratory resistance increase is usually due to, say, kinking of the tube, or there is some kink in the circuit. So make sure you look for that.
Anuj bhai, last 5 minutes.
Yeah, I'm nearly finished.
Okay, thank you.
So the other part of the inspiratory, if you have inappropriate flow, the whole loop will be either thinner, or you will have this kind of active inspiration by the baby that suggests air hunger. Okay, so if the baby is having air hunger, even during the ventilator inspiration, the baby is showing signs of active inspiration. Okay, so that suggests there is inadequate inspiratory flow. You need to increase the flow. The last loop is the flow volume loop. In this, so you are starting with a functional residual capacity. At the flow starts up, the flow is on the y-axis and the volume on the x-axis. You achieve a peak inspiratory flow rate, and then once the tidal volume is achieved, your expiration begins, go towards the peak expiration flow and back to the baseline. Where is that used? So again, that is going to tell you the leak, air trapping, resistance, and secretions. So in the air, this is a normal loop. When you have a leak, your volume is not reaching the baseline. If you have air trapping, the flow is not reaching the baseline. Okay. If you have increased airway resistance, you have this scooped out pattern and the reduced PFR, again with things like, say, bronchoconstriction. If you have airways or condensate in the circuit, you will see up zigzag lines like this in the expiratory phase. If you have a compression around the whole of the, if the whole loop is compressed, that suggests there is some compression around the ET tube also. So these are the 5 scalars, the scalars and the loops in details. But one must remember that there are limitations of using any equipment. There can be technical problems. Your flow sensor may not be working appropriately. There could be interpatient variability. You or the operator may not be experienced. So you have to kind of gain experience in looking at these graphs. And there is an expense attached to the flow sensor as well. If you're using a disposable one, it's fairly expensive. But what is more useful is observing the trends. So rather than a single value, observing the trends. So looking at the real-time monitoring, recognize the patterns, and you're going to use it with other parameters, say your clinical parameters, what is the saturations like, what is the perfusion like. So clinical correlation is always necessary. And once you have been doing it for some time, you'll become an expert like Ted. Okay? Thank you. I'm happy to take any questions if there are.
Yeah, Anuj bhai, it was a very excellent talk. And I'm not seeing any questions in the chat box, but there is one question from my side.
Yes, please.
We have been using pulmonary graphics since so many years now.
Yeah.
Is there any evidence which shows that with the use of pulmonary graphics, the results or the outcomes are better?
So there is some data now. So to show that, see, the data is increasing every day, but pulmonary graphics, the widespread use has been over the last, say, 10 years or so. And definitely it is showing that there is improvement in the patient outcome. You're ventilating for shorter periods. You're avoiding sort of volume traumas or so. Volume targeted modes have clearly been shown that they are reducing the risk of bronchopulmonary dysplasia. So there is evidence that this will improve the clinical care.
Yeah. Yeah, excellent talk. Any more questions? Not seeing any questions. Okay, thank you, Dr. Anuj. Ashish bhai is here. Ashish bhai, welcome.
Welcome. Sorry to join late.
Good evening, sir.
Good evening, those. First time with emergency. Yeah.
That's the life of a neonatologist.
Yeah.
So we have finished first talk of Dr. Anuj, and Dr. Archana is ready. We are planning for the second talk now. So I would just introduce Dr. Archana. Dr. Archana Rai is a consultant neonatologist at Nirmal Hospital, Surat. She did a DCH and DNB, and then she did a DM in neonatology from Madras Medical College. And she will, her areas of interest are nutrition and developmental supportive care. So I welcome Dr. Archana for giving her a talk on hybrid modes of ventilation. Dr. Archana.
My slide visible?
Not yet.
No, you have not shared your screen. Screen sharing?
I started screen sharing, sir.
We are not able to see your screen.
Now, sir?
Yeah, now it is okay. Yeah, we are seeing your first slide.
Okay, sir. So, good evening, everyone. I will be dealing with the hybrid ventilation and newer ventilation modes used in neonates. So, our learning objectives will be what is hybrid ventilation, what are the different modes, and what are the newer modes, and the take-home message in the last. So, what is hybrid ventilation? It combines the benefits of delivering the desired tidal volume using a pressure limit ventilation. The various examples of hybrid ventilation are SIMV mode combined with PSV mode, pressure support ventilation mode, or volume guarantee, or PRVC mode, or TTV mode, or VAPS mode. So we will be dealing one by one each. Just a brief review. There are primary three variables. They are during the pressure triggered ventilation. First is the trigger, which is the A point, and which initiates the inflation. Another variable is limit, that is B point, which determines how the pressure and flow will be regulated during the inflation. And the third one is the C point, that is cycling, which causes ventilator to move from the inspiratory phase to the expiratory phase. So cycling can be of two types, time cycling and flow cycling. What is time cycling? In this, a preset time interval is set and the inspiration ends when it is elapsed. And in flow cycling, when the preset flow is attained, the inspiration moves to the expiratory phase. So as our talk is first on the SIMV mode combined with the PSV mode, I just want to have a brief review of the SIMV mode. In this is a time cycle mode, and it is a pressure limited mode. In this, the set number of mechanical inflations will be given, which will be synchronized with the infant's respiratory effort. The disadvantage is that the breaths which are of excess of the set inflations will not be supported. So that's why there will be some inspiratory synchrony, but there will be complete expiratory synchrony. And also there will be difference between the tidal volume achieved between the supported and the unsupported breaths. So therefore, there will be more work of breathing. As we see in the graphics of the SIMV mode, these are the supported inflations and these are the spontaneous effort of the baby. So in this flow scalar, the volume scale, we can see that the supported breaths are having a good tidal volume, and the breaths which are spontaneous, they are basically having a dead space ventilation. So to and also the expiratory asynchrony which happens in the SIMV mode or the assist control mode is because, like lastly yesterday we discussed, is because there is the difference in the inspiratory time of the baby and the ventilator. It happens when the baby has completed the inspiratory phase, but the ventilator is still giving the inflation breaths. Because the baby TI is usually shorter than the ventilator TI. So in SIMV, in assist control mode, basically the trigger is taken care of, but not the cyclical part. So here comes into the play of pressure support ventilation. How it is helpful? improve the cycling because it is a flow cycle and not the time cycle. So the inspiration ends when the peak flow is achieved after a certain percentage of peak flow. It will much better with this waveforms. The first half on the left side is time cycle breaths. In this, we can see because of the time cycling, there is inspiratory hold. And when this mode is changed to pressure support ventilation, it changes into flow cycling. Once the flow reaches 15% of the peak flow, the inspiration ends and the it goes into expiratory phase. So we usually set termination sensitivity in this, which is usually between 5 to 50% and usually set at 15% of. What does the termination sensitivity means? That once the peak flow, 15% of the peak flow has been achieved, the baby will go from the inspiratory phase to the expiratory phase. That's why eliminating the inspiratory hold. In this, if we can see, the inspiratory hold is not there in the flow scalar. And also in the PSV mode, we can see that the pressure scalars are most kind of a fish fin kind of pattern. And in the time cycle ventilation, in that there will be pressure will be given for the TI time and there will be inspiratory hold. So in PSV mode, the baby decides the inspiratory time. So if the baby is breathing faster, there will be shorter TI, and this shorter TI can be a disadvantage in the PSV mode because it will cause low MAP and thereby causing atelectasis. So once if there is shorter TI because of the faster breathing and adequate MAP is not generating, we have to adjust the PEEP. So the advantages of PSV modes are all the breaths are supported like assist control or the SIPPV mode. There will be inspiratory synchrony like SIMV mode and assist control modes, and there will be expiratory synchrony. That is advantage of the PSV mode from the other pressure triggered mode. And because of this, there will be less fluctuations in the intrathoracic and intracranial pressure, so less chances of IVH is there. And PSV can be used as a standalone mode, or it can be combined with the SIV mode. When it is helpful with the SIMV mode is when we are weaning the baby from the SIMV mode, we are gradually tapering the rate of the set rate of the SIMV mode. When the rate is less than 30, so many of the breaths will not be supported. So at that time, if we add the PSV mode, those breaths will be supported, and thereby we will have a better VT reach rather than only using the SIMV mode. So this graph will depict the same. So this is only the SIMV. In this, these are the mechanical breaths, and these are the spontaneous breaths of the baby. So because of the spontaneous death, the V tidal is not achieved. It is mostly of the dead space ventilation. Once we add the PSV mode, the PSV will support the unsupported breaths and thereby achieving a more or less uniform tidal volume as compared what the SIMV was giving previously. So thereby it will have, the baby will have less tachypnea and there will be more efficient breathing pattern. But as we have just discussed, the disadvantage of PSV mode is because of the faster rate, there will be shorter TI leading to lower MAP and thereby causing atelectasis. So another is if the leak is more than the threshold for the inflation termination, then there will be no flow cycling. So some ventilators, they have leak adapted PSV mode. So if we are having that, we can very well use. Otherwise, that is one of the disadvantages with PSV mode. Moving to volume target ventilation, as there are lots of evidence stating that it's not the pressure without generating the excessive tidal volume causing the ventilator-induced lung injury. It is mostly the tidal volume which is the critical determinant of the villi. So how this so to overcome this, the volume control mode was brought into scenario. Like how it is different from the pressure control mode. If we see the pressure control mode, we set the pressure and it cycles by the time of the flow, and the volume generated will depend upon the compliance of the baby's respiratory system. If in the volume control, what is set is volume. The set volume will be delivered and the pressure will rise passively. If we see here in volume control ventilation, the pressure is peaked at the end of the inspiration. And in the pressure control, it is peaked at the start of inspiration. But there was some disadvantage with the volume control mode, because the volume which is measured is usually what is being injected into the ventilator, that is at the ventilator end of the circuit, and not at what is entering the babies during inspiration or expiration. And secondly, doesn't account for the compression of the gases that occurs usually in the circuit and the humidifier, and also the circuit's compliance may change. So it doesn't account for all these two stuffs also. Thirdly, it also doesn't account for the variable leak, which can be very large, and because of the uncuffed ET tube used in the neonates. So volume control mode usually doesn't work if the leak is more than 50%. So overcoming these limitations, the separate flow sensor can be used at the proximal end. And another troubleshooting is to deliver a target VT of expiration of 5 to 6 ml per kg. We can set a tidal volume delivery of usually of 10 to 12 ml per kg, so that we can get a expirated tidal volume of 5 to 6. So on the volume control mode, because of volume control mode, these were the disadvantages of the tubing compliance or compressibility of the circuit and the ET leak. The another mode was brought into the scenario. It was volume guarantee. What is volume guarantee? It is basically the volume compliance with some intelligence from the ventilator. So what this ventilator do in volume guarantee, it usually senses the V tidal delivered before the previous breaths on the same breath, and then it manipulates the pressure to achieve a set tidal volume. So how the volume control ventilation and the volume targeted ventilation differ? So control variable in the volume control is volume, and in the pressure target ventilation, it is pressure. And in this, the cycling in the volume control, the cycling occurs by the volume cycling, and in the VTV, the cycling occurs by flow time cycle, that is a pressure control ventilator. How we set the VT? VT will be set by the clinician in both, but the determinant of VT reaching the baby will be different in the two. In the volume target ventilation, only ET leaks are taken into consideration, and in the volume control, we have to take into consideration the circuit compliance and the ET leaks. As we have just discussed, in the volume control ventilation, the PIP peak at the end of the inspiration, and the volume target ventilation, as it is a pressure mode, the peak is usually early in the inspiration. In volume control, how the PIP is determined, it is basically based on the lung compliance. Better the compliance, the lower the will be the PIP. It will be adjusted by the ventilator. And in the volume target ventilation, what happens? The ventilator will sense each breath of either the previous breath or the same breath, and then assess that it is sufficient to deliver the set tidal volume or not, and then in the subsequent breaths it will make an adjustments. So what is VTV? It is the pressure control modalities of ventilation in which the automatic adjustment of the inflation pressure is done to target a user set tidal volume. In most of the ventilators, usually the exhale tidal volume is usually used. So just now we have just discussed, like it is a pressure control, time of flow cycle, volume targeted. In this, we first choose the V target, what we have set for the as per the baby's condition, and a pressure limit. And then once then the microprocessor will compare the exhale VT of the previous inflation, and then it will adjust the working pressure. At this time, we have to keep looking on the working pressure, because the pressure limit what we have set has to be again reset depending on the working pressure as per the baby's clinical condition. It should be usually set 3 to 5 centimeters above the working pressure. And usually several cycles of inflations are needed to reach a target VT. VG can be combined with AC mode or SIMV or PSV modes. This is the algorithm. Like we set the first V tidal, we set the PIP limit, we set the P, TI in the flow. Then the ventilator delivers the breath and it will see how much tidal volume is generated. And like in this, it will be much clearer. This is the first we will set a targeted tidal volume. This is the targeted tidal volume. And this is the pressure limit what we have set for the baby. So as the ventilator has delivered one breath is delivered. So it senses that this breath was okay, and it will sense how much tidal volume is delivered to the baby. So as it was reaching the targeted tidal volume, the ventilator has again given the same pressure PIP to the baby again. So that, but at this time, when the ventilator microprocessor senses that this volume has not reached the targeted tidal volume, in the next breath, it will increase the working PIP. So in this working PIP increase, at this time, then the ventilator senses, okay, this has reached the targeted tidal volume. The next breath, it will deliver the same PIP. This time, but it has overshooted our targeted tidal volume. So in the next breath, our working PIP will get down. So we have to keep seeing the working pressure. We have to keep a note on the working pressure and the pressure limit, so that it should not be more than 3 to 5 centimeters of water. Another safety mechanism in volume guarantee is that if the ventilator senses that the breath delivered has got more than 130% of the tidal volume as compared to what has been targeted, it will terminate the inflation. So like we have discussed, it will sense from the previous breaths, the pressure delivered and the tidal volume generated. But it is not as that simple, because if the baby is having spontaneous efforts, the baby will be having it will be very difficult for the ventilator to sense how much pressure to generate. Like this is the ventilator given breath and these are the spontaneous efforts. So the pressure generated are very variable, and that's why the target volume generated are very variable. So some ventilators like Drager, it uses algorithm in which it senses the trigger and the untriggered breath, like the spontaneous and the machine-induced breaths. And it has got a software so that the working pressure of the next cycle will be set as per the last triggered breath. Last breath of the same time, is it was triggered or not triggered, it will sense. If it was a triggered breath, that the last working pressure it will see, and the volume generated in that it will see, and then it will, for the next triggered bed, it will adjust according to the last triggered bed. And if it was only the mechanical ventilator induced inflations, then for the next mechanical ventilator induced inflations, then it will use that for the previous, like the triggered and non-triggered beds. So is VG a misnomer? Because we have seen that it is not uniformly delivering the tidal volume. But it is actually helpful, because as the VT fluctuate, and this physiological variability is helpful in avoiding the atelectasis, and it is more physiological also. So how to start a volume target ventilation? As soon as we have the baby and we have the machine having the volume guarantee mode, we can very well use it. Firstly, we have to choose any of the basic pressure triggered ventilator modes, like assist control, pressure assist control, or PC pressure support ventilation. We can have a backup rate of less than 10 per minute of the spontaneous breath. We have to select the PEEP as per the diagnosis, FiO2, and the current condition of the baby. And one has to make sure that flow sensors are working properly and calibrated, because tidal expiration is going to be calculated through that only. Usually the targeted expired tidal volume is usually set between 4 to 6 ml per kg, and the pressure limit is set, and the ventilator will adjust the working pressure. Once we know the working pressure, we should again reset the PIP limit to 3 to 5 centimeters of water, that is 30 to 50% above the working pressure. And we should always use the proximal flow sensor. And why VTV doesn't fit all with the same size, like we have to target this expired tidal volume as per the patient's condition. This can be calculated based on the infant size, various pulmonary diagnoses the patient is having, and the what modes we are using. Like the smaller the baby, there will be more of the dead space because of the instruments like the flow sensor and all. So we have to set a higher tidal volume. And when the baby is older, like more than 2 weeks old, because of the physiological tracheomegaly, there will be more loss. So we have to set a high tidal volume in that also. In diagnosis, if the baby is having RDS, we have, and MS and BPD, we have to keep it on the higher side, the tidal volume, because there will be more of the dead space ventilation happening. And in the synchronization mode, if we see, VG is more effective when used with the AC or the PSC mode rather than the SIMV inflation mode, because in AC and PSV, all the inflations will be subjected to volume targeting.
So this is just 5 more minutes.
Okay, sir. So we have to again keep on changing the various PIP levels, seeing on the working PIP what the baby is getting. Usually VT adjustments can be done only till 3.5 to 4 ml per kg, and in the decrements of 0.5 ml per kg. And usually birth weight is usually used to determine the VT, but when the baby is gaining weight, we have to take that into consideration. In VG, usually the weaning is automatic, and we usually don't reduce VT below 3.5 ml per kg. There are many advantages of volume target ventilation. This Cochrane review showing that there is less chance of BPD, grade 3 for IVH, PVL, pneumothorax, hypocapnia, and number of days on the mechanical ventilator. I will overcome this troubleshooting part. There can be limitation of VG if there are larger leaks. Then it is very difficult to deliver the volume guarantee. Some ventilators are having this compensation mechanism, like 40% leak compensation is there in Dragar and 80% in VN500. Another mode is PRVC mode. In this, what usually happens is we set first the VTAD and the pressure limit. The first breath is given as a volume control breath. Then from this volume control breath, the ventilator will know the compliance and will calculate the PIP. This PIP will be used, 75% of this PIP will be used to deliver the target ventilation. Like 3 to 4 breaths it will give, and then it will see how much we have reached the tidal ventilation. And then if we have not achieved the tidal volume, if we have not reached the tidal volume, then the PIP will be increased by 1 to 3 centimeters of water. So in this, usually the TI is fixed. So PRVC mode is there in the servo I ventilator, and in this the VT measure is usually at the ventilator end, and this has been overcome in the new ventilators of servo modes like N and U, where it usually work like volume guarantee. Another mode is VAPS mode. What is VAPS? Volume assured pressure support mode. In this, what happens? First, we will first breath will be given as a pressure pressure mode, and it will see how much if we have achieved the tidal volume or not. So in this, the breath, we have achieved the tidal volume. So it will end the inspiration and goes into the expiration. But if in some cases, like if the compliance is decreasing or resistance is increasing, once the pressure has generated, but the tidal volume has not achieved, this mode will help in achieving this tidal volume. So by how it will achieve in tidal volume, it will increase the pressure limit, and it will keep the inspiratory flow maintained till the time a tidal volume has been reached. Once the tidal volume has been reached, the cycle will go into expiratory phase. So it is in Hamilton ventilators. Drawback is like inspiratory VT is usually used and automatic weaning is not possible. What is targeted tidal volume? It is more or less like VG. It is mode in SLE 4000 or 5000 ventilators. In this, only extra is like it uses the increase in the rise time of the pressure waveform to effectively limit the tidal volume to the desired target, and leak compensation is also there. What is mandatory midden ventilation? In mandatory midden ventilation, it uses VTA and the rate. So it delivers the minimum minute ventilation if the baby is not having any spontaneous efforts. So it will see if the baby, and once the baby started having spontaneous breaths, it will start decreasing the rate if the baby is able to achieve our target tidal volume. Issues with this is etelectricity can happen if it is not matched with the expiratory tidal volume. Another is NAVA, lastly. So what is NAVA? Neurally adjusted ventilatory assist. Usually what happens, central nervous system will give sensation, like it will go through phrenic nerve, it will cause diaphragmatic excitation, it will cause contraction of the diaphragm, thereby causing the expansion of the chest wall and the lung, and thereby variation in the airway pressure, flow, and volume. This is what normal ventilators are doing. What NAVA will usually do, it senses the diaphragmatic excitation, and then it will give the input to the ventilator. In this, what is being used is this electrodes from which eddy currents are being generated, but it is not being used commonly, so we will not go much into this now. So take-home messages are all assist control mode, SI, pressure support mode are better, and but in the current era, we should go with the volume ventilation, as there are robust data that volume is the main culprit. So VG has, as we have seen, VG has got multiple advantages, and we have to look for the ventilator where the ET leaks are less or their compensation are there. And we have to use the tidal volume as per the baby's clinical condition. So thank you very much.
Thank you, Dr. Archana, for a very a deep understanding of all the newer modes of ventilation. And I'm not seeing any queries here. Ashish Bhai?
Yeah, Archana did well, but only thing that you have to, was running for the time limit. Would have wished you have got more detail about the similar volume guarantee modes. It was a really good presentation, but would have wished if you could have, if you got more time to present this, isn't it? Yeah.
So only 30 minutes was there, yes.
Yeah. Only thing is that you mentioned about the VAG, which is in the VG, when you compare the table of VG and volume guarantee and target, it is important to know that volume guarantee is never a standalone mode. It is always added to the SIMV.
Added to SIMV, yes.
And because of that, you have some disadvantage because you are actually working as a pressure mode, and then volume is targeted. So
Yes.
you are early said that pressure peaks are becoming early in comparison to volume control mode, where the pressure peaks are becoming late. I mean, and at the end of the breathing, and
Yes,
that's a disadvantage there. Having said that, it helps in keeping the lung open also. So in a way, it is good. In a way, still you are working on the pressure mode with volume guarantee. That's what hybrid mode works, but that's fine. Second thing was about the pressure assured volumes or pressure regular volume control, PRVC. Pressure regular volume control. That is a mode. It is like a VG. You are absolutely right. But here there is no Pmax. Pmax can go up by 3 and come down by 5. That's only difference between PSV VG and PRVS.
Yes.
Because in VG PSV you can't change the Pmax. Once it is fixed, they will make sure that within that Pmax volume will be given. And if not, it will give the alarm that check the settings. With PRVC mode, there is an advantage that Pmax can go up and down.
Yes,
but with VG, PSV, VG and the PRVS, only problem is it is always running behind the time because it is not within the breath. It is coming in the next 2 or 3 breaths.
Yes.
And that next 2 or 3 may be good breaths. So this is not required. Adjustment is not required in those breaths.
Yes.
So anyway, it's good one, but presentation is really good. I must say that. Only thing is that we need to give you more time to present it well. Great. Thank you very much. Very well explained.
Thank you, sir.
See you tomorrow.
Okay, sir.
Yeah. Bring this PPT tomorrow. I need that.
Okay, sir. Sure, sir.
Yeah, good. So next is Dr. Sachin himself. Tendulkar is coming to bat. Tendulkar in the sense that he had his he did his fellowship from Pune, Bharati Vidyapit, and after that he's working at Surat at Anand Children Hospital. He has saved so many ill-bedded babies. He is one of the leading faculty or is the leading user of high frequency in the country. Very well versed with the sensormatics using for ages and always looking for the newer ways to improve the quality of practice in newborn. Very good friend of mine, Sachin. Welcome, and you can go ahead, please. Floor is yours.
Yes, thank you, Ashish bhai. I think my screen is visible to everyone.
Yep.
Okay. So, first of all, thank you, Ashish bhai, and the whole team of Gujneocon for arranging this online talk so that in a day we can cover most of the things about ventilation, and on the practical workstations we can have a good discussion once we are clear with the theoretical aspects. So today in my talk of 40 minutes, I'll try to cover basic aspects of high frequency ventilation. This has been very close to my heart. I've been using this machine since last about 20 years now. So this is a baby on the high frequency. You have seen that these are sick babies. Most of the time, high frequency is used as a rescue mode. So most of the babies did not do good on the conventional. They have been shifted to HFO. So these are one of the sickest babies in our units. And this is the baby of high frequency with nitric oxides. You can see multiple lines, multiple infusions, ventilator, nitric oxide, multiple monitoring, and all these. These are one of the sickest babies. So it requires a very close and intensive monitoring and understanding the basic concept of high frequency ventilator. So today I'm here to talk about, I want you everyone to focus about what is acute lung injury and what is lung protective ventilation strategy, because this is the basic for any type of ventilation. So I want everyone to understand those things. Then what is the role of high frequency in these type of disease, basic knobs and the monitoring on the high frequency and the evidences. So basically, what is high frequency? It is ventilating at very supraphysiological rates. That is the rates which are very high as compared to the normal tidal breathing. And along with that, using very, very less tidal volumes. So the frequency what we use is in the range of 6 to 15. So that is about 360 to 900 breaths per minute. And the tidal volume, what we get in the HFO is almost as equal to or less than the dead space ventilation. So how it is useful, I'll try to discuss it. So high frequency, it's not a new ventilator. If you see the history of high frequency, it has been there since last about 40 years now. A lot of evidences since last 30, 35 years, and a lot of meta-analysis and a lot of trials are there. It is basically a CPAP machine with some oscillation. So it is basically a CPAP with a wiggle. You are delivering CPAP, and along with that, you are delivering some oscillations which are doing the ventilation. The common disease what we use to ventilate in newborns is RDS, MS, pneumonias, pulmonary hemorrhage. In all these conditions, we have been using conventional ventilator, and there is a role of high frequency in all of the disease as per the disease pathophysiology. So what is most important is that we should know what pathology is running behind the problem and then how the ventilation concept would work for that. So do we really need a high frequency ventilator? Because we have been using conventional since so many years now. So is there a role of high frequency in any of these disorders? So first of all, let us try to understand what is acute lung injury. I want everyone to understand that this is the normal alveoli where you can see a good open alveoli, no damage to the interstitium, the basement member is healthy. So this is the endothelial capilla. This is what a normal lung will have, and these babies will have a very good pulmonary function. Most of the time when we have diseases where there is hypoxia, there is some or the other of the pathology which is running like this. Either there could be some inflammatory mediators which are working like this. So there's a lot of cellular debris, the interleukins, the procollagen, all these things. The gap in the interstitium is increased. There is damage to the endothelium. The surfactant lining has been damaged. And there are a lot of inflammatory markers here. So basically, this is the damaged alveoli. So you should understand that at any given point of the disease, when the alveoli is damaged, it is going to lead to less volume, alveolar collapse, and a lot of inflammatory markers which are there. So there is surfactant deficiency, which is common in preterm babies, or surfactant inhibition, which occurs in term babies with severe meconium aspirations, with congenital pneumonias and all these conditions. So the disease pathology, in fact, remains the same, that there is damage to the alveoli. There is alveolar collapse, which will lead to severe hypoxia and hypercapnia, and which will, because of this, we will need to put the patient on mechanical ventilation. So this is just a video presentation of how tidal breathing occurs. In our conventional breathing, on inspiration, the alveoli open up. At the end of expiration, the alveoli usually close. This is what occurs in tidal breathing, in our conventional breathing, which occurs in all of us and all of the normal disease. So when I put it on a graph on a PV loop, as we saw today in the previous lectures, this is the inspiration. Gradually, we are increasing the pressures and going till peak. At the end of the inspiration, there is some amount of beaking. With the increase in pressure, the volumes are not increasing accordingly. There is a beaking, which is over distension. And then during expiration, there is gradually the loop comes down. At the end of expiration, there is again a part where there is atelectasis. So this is basically in normal tidal breathing. At the starting and at the end, there are some areas where there will be atelectasis, and there are some areas there will be overinflation. So when we want to ventilate in the middle zone, which is the safe zone. And how high frequency helps here, I'll just show you. So any type of ventilator will lead to some form of ventilation-induced lung injury. And we are aware of this concept since last about 25, 30 years. The combination of the following processes do occur. Apart from oxidant injury, there is baro, volume, atelectotrauma, biotrauma, rheotrauma. One by one, as I showed you in the graph, mechanical ventilation at the lower expiratory volumes may be inefficient to maintain the alveoli to keep it open. So this is basically the alveolar collapse which occurs. And in tidal breathing, with repetitive alveolar collapse and reopening, there is a loss of the lung volume, which is called as atelectotrauma. The quantitative and qualitative loss of surfactant may predispose to atelectotrauma.
Thank you,
which is the most common thing what we see in respiratory distress syndrome of the preterm babies. Second thing is when we use high pressures, the high pressures will lead to over distension and gross tissue injury, which will lead to air leak syndromes like the pneumothoraces, pneumomediastinum, pneumopericardium, which is a type of ventilation-induced lung injury because of high pressures. Because of high volumes, if you see, there is significant over distension of the alveolar damage occurs. The pulmonary capillary membrane, which will get damaged, and it will lead to interstitial edema, pulmonary edema type of picture. And excessive and inspiratory alveolar volumes are the major determinant of volume trauma. As Dr. Archana told, that volumes are the most important thing because the most damage is caused because of the volumes. Volume trauma is one of the most important aspects of ventilation-induced lung injury. So the cycle is like that. Of surfactant, atelectasis. Along with that, there is high distending pressures, and there is a lot of inflammation, alveolar stretch, distortion, haline membrane formation. And then because of that, we need more and more pressures, more volumes, more FiO2, and leading to more and more of the volume trauma. So it's basically a vicious cycle where the volume trauma, barotrauma, and the biotrauma continues to increase on the mechanical ventilation, and the patient lands up into BPTA PI. So if you cannot prevent the injury sequence, then the target goal is to interrupt the sequence of events. High frequency does not reverse the injury, but it will interrupt the progression of the injury. So as we saw that with mechanical ventilation, there is a lot of ventilation-induced lung injury, and lung protective strategies are helpful in this, whether on the conventional or on the high-frequency ventilator. This is an alveoli, a collapsed alveoli, and with recruitment, you see applying more pressures, there is opening of the alveoli, which you can see here. So the alveoli, which at the starting of the video was all closed, now with proper recruitment strategies, you can see the alveoli which are quite open. And these open alveoli will take good part in ventilation. It will help in oxygenation. So this is what our target is. We want to have a good recruited lung. If you see this video, how we start the ventilation, whenever there is a alveolar collapse, we start the patient on ventilator, we gradually start increasing the pressures. Once we are increasing the pressures, that is, we are trying to recruit the patients, there is gradually opening of the alveoli. You can see that with increasing the pressure, there are some alveoli which were completely closed at the starting, with increasing in the pressures and recruitment, you can see the alveoli opening up. So this alveoli which was closed is opening up. This alveoli which was closed is opening up. And gradually, with steady increase in the pressures, you can have lung recruitment. You can see there are different areas which are still collapsed. Still this part of the lung is collapsed, this part is collapsed. And with gradual increasing, this was a collapsed alveoli which is opening up. So this is what we call it as lung recruitment. This is all on the alveolar surface, but what we can see is an improvement in the oxygenation once you are recruiting this. So our target is to open up the alveoli and keep the alveoli open. So you can see this now we are decreasing the pressures. You are now on the expiratory loop. You are decreasing the pressures. The alveoli which were open, we are again starting closing up. So this was an alveoli which was open. Now it is again closing. So you can see the alveolar collapse again. And once with decreasing pressure, this is the closing pressure. Now you can see the alveoli which were recruited with our strategy, they have again started closing. If you see this on the macro and the alveolar level with lung recruitment, this is a very bad collapse alveoli, lung which you can see here. On the microscopic level, this is the alveoli with tidal breathing. After recruitment, this is after recruitment, you can see this alveoli which is a healthy lung, opened up lung, and this is the alveoli which are looking wide open at the end of recruitment. So this is before recruitment, this is after recruitment. This is what occurs in the high frequency. In high frequency after recruitment, the alveoli will remain open, will start vibrating like this, what you can see here. And what you saw in the first video on the tidal breathing, that at the end of expiration, there was collapse. Even at the peak of inspiration, there was some overinflation. This does not occur in high frequency if you are using the optimum map. So this is basically what is important, that you start your ventilation here, you have a completely collapsed lung. You can see the lung volume here. You can see a very collapsed lung here. And you start ventilating the child, you are recruiting at these pressures, the lung starts opening up. As you saw in the alveoli also, the lung volume is increasing. You gradually still go ahead, you are recruiting the lung, and then at some stage, your saturations do not improve, the lung is overinflated, and then you try to bring down the pressures here. So this is on the expiratory limb, but this is after recruitment. See, if you are seeing the same pressures before or this pressure, the alveoli was completely recruited, or completely collapsed. And now you can see after recruitment, the difference in the lung volume. If you see it in this chart, this is called as the hysteresis. This is before recruitment, this is after recruitment. So after recruitment, you will have a good lung volume as compared to the same pressures which were used previously. And our target of ventilation in high frequency is to recruit the lungs and then come here and keep the lung open at this stage on the expiratory side. This sounds very interesting on the diagrams, but on the patient care, it is a little bit different. So I will talk about the clinical tips also. So the target is to open up the lung and keep it open. In conventional, there are swings between the zones of injury from inspiration to expiration, as I showed you. So these are the zones where there is a problem in conventional ventilator. In high frequency, the whole cycle operates in between if you have recruited it properly. So we are avoiding this zone of overinflation. We are avoiding this zone of atelectasis. So high frequency helps to decrease the lung injury, and it is theoretically better as compared to conventional as a lung protective strategy. If you see the pressure transmission, what occurs in conventional ventilator, the pressures which are at the endotracheal tube level, almost the same pressures go till the tertiary alveolar bronch. In high frequency, there is significant attenuation of the pressure as the air moves towards the alveolar level. The thing, what you see on the endotracheal tube level, but if you see what goes to the left, it is hardly just a mild fluctuation of the pressure waveforms you can see here. And because of that, the tidal volume which is generated at the tertiary alveolar level is very, very low. And because of that, the volume trauma which occurs is quite less. If you talk about hemodynamics, the pulmonary vascular resistance will have some element of pulmonary hypertension also. Pulmonary hypertension is directly correlating with the lung volume. If you have recruited the lung properly, then your pulmonary vascular resistance is going to the minimum. If there is atelectasis, then the PVR is going to be high. If the high, then it's going to be high. So our target would be to have an optimum lung volume. With that, the pulmonary pressures are going to be the minimum. So even in cases of pulmonary hypertension, the first therapy would be recruit the lungs and then use your pulmonary vasodilators as and when needed. So what is the optimized lung volume strategy? It is basically to increase the lung volume above the critical opening pressure to the optimum and keep it there in inspiration as expiration. As I showed you on the gram, there is a good benefit in terms of good gas distribution, reduce regional atelectasis, there is the maximum gas exchange area, decrease PQ or VQ mismatch, reduction in the intrapulmonary shunting, and a good reducing the oxygen exposure. Once your lungs are open, they do not require oxygen. So your FI to requirement would significantly come down after recruitment. So as a lung protective strategy, you have to recruit the collapsed alveoli, which is the first thing. Second would be stabilize the alveoli during in and expiration. So you have to open up the lung and then you have to keep it open. And you have to prevent the end inspiratory overdistension. You have to prevent the peaking, what you see on the graph. And then with this all things, you need to come down on your FiO2. You have to reduce the oxygen concentration. So this is basically our theme of lung protective ventilation. And so we want to ventilate at the greatest compliance, as we shown, I showed you on the graph. So that is the optimal lung volume or the open lung ventilation strategy. So how does high frequency fit into these principles? So high frequency, as I told you, it is high rates with low tidal volumes. It's basically a CPAP machine with a piston which displaces the gas. So it is basically CPAP superimposed by some oscillations. There is an active exhalation on the sensor medics because the inspiration and the expiration is basically related to the movement of the piston. I'll show you in a graph also. In the tidal volumes which are generated, as I showed you, the pressure dissipation to the tertiary alveoli is very, very minimum. So the changes in tidal volume are very less and it is almost equal to the anatomical dead space, like about 2 ml per kg. We use very high rates in that, and at any given point of time, the mean airway pressure is relatively less as compared to that on the conventional ventilator. One of the most important things about high frequency is there is decoupling of oxygenation and ventilation. So what do I mean by that? It means that oxygenation and ventilation are little bit different. It is not the same in conventional ventilator. If on conventional ventilator your patient is desaturating, you will increase the PIP or you might increase the PEEP according to the lung compliance. You might increase the I time to recruit the lung. So these are the things which will improve your mean airway pressure, but along with that, they will lead to changes in your PCO2 also, in your ventilation also. In high frequency ventilator, these two things are a little bit different. So we can manage oxygenation and carbon dioxide in a little bit different way, in an almost independent way. And this is a place where it is very, very useful. Once your oxygenation is okay and you have to take care of carbon dioxide, this machine works well. And I'll show you in some charts later on. So what are the indications of high frequency? There is inadequate oxygenation that cannot be safely treated without any potential toxic ventilator settings. What is toxic ventilator settings? We are using very high pressures, high volumes, high FiO2s. In all these things, as I showed you, there is an increased risk of ventilation-induced lung injury. So if you want to define that for any patient, a PIP of more than 30 would be a very high pressure. FiO2 more than 60% any given point of time, or you're not able to wean off, that is also very high settings. Your mean airway pressure of more than 12 on any mode of ventilator is a very high setting, and there the risk of ventilation-induced lung injury would be more. So these type of patients these are all subjective, and these are the indications for high frequency ventilator. Any PEEP more than 8 centimeter, or your OI more than 12 to 14, you know the diagram, you know the formula for it. So indirectly, when your lungs are bad, requiring high pressures, high volumes, high FiO2s, then you can shift over to high frequency ventilator. Other indications, pulmonary hemorrhage is one of the indications where it can be very helpful to recruit the lungs. And as I told you, there is decoupling of oxygenation ventilation, inadequate alveolar ventilation with respiratory acidosis. If you have severe respiratory acidosis because of any other cause and you're not able to maintain on conventional, then high frequency would help in those cases. Coming to the types of high frequency available in the market, sensor medics has been there since last 40 years. It is the gold standard of high frequency oscillatory ventilator. Now, SLE 5000, 6000 is there, Fabian is there, the Draeger VN series is there. So almost there are about 7-8 different types of high frequency oscillatory ventilators which are available in the market. So I'm not comparing the machines, but you should know your machine well. That is important because the functioning of the machines are a little bit different. So a whole lot of different machines are available in the market. The mechanism of gas exchange in one sentence, no one knows. There is a lot of theory related to how does the gas exchange occur. It is a mixture of cardiogenic mixing, molecular diffusion, the turbulent gas flow, the pendulum effect, and all these things are theories from how the gas exchange occurs in high frequency ventilator. This is how a patient looks on the high frequency. As I was talking about it, there is a oscillation. There are oscillations. It is basically CPAP along with some oscillations. If you see very closely, you can see that the chest of the baby is vibrating. These vibrations or the oscillations, we call it as the wiggle. And this wiggle factor is something which we have to monitor on the bedside very, very closely. It is indirectly related to the carbon dioxide washout. So these wiggles are directly correlated to the tidal volumes, what the baby is generating, which is indirectly related to the amplitude what we are using. So this is the sensor medics on which the patient is there. I'm not going into the specifics of the different machines, but a frequency of 3 to 15, a pressure amplitude from 8 to 100, and an I time from 30 to 50 is what the machine can deliver. There is a valve here, and there is a piston. The piston moves, and along with the bias flow, the machine will deliver the mean airway pressure here. The tidal volume, as I told you, is very less here in high frequency ventilator. If we talk about oxygenation ventilation in a different way, then oxygenation is dependent on only two things in the high frequency ventilator. There are only two knobs. FiO2 is something which you don't have to think a lot. It is only the one button which is the mean airway pressure, and indirectly mean airway pressure means you should know where your disease pathology lies, at what part of the graph you are there, and according to that you can use your mean airway pressure. Most of the time oxygenation, the mean airway pressure, what we need to start off is basically a little bit higher than what we were on the conventional ventilator when we are using as a rescue mode. So we start with HFO with the FiO2 to get a good saturation. You may start even with 100% if your baby is desaturating, and you start on HFO with a MAP at least 2 to 3 above your conventional ventilator. If you are on a MAP of 12 on the conventional and you're not maintaining good saturations, then start with MAP of 13, 14. Gradually increase the MAP until you get a good saturation. And once your saturations are fine, then you start bringing down your FiO2. And once you're bringing down your FiO2, baby is able to maintain, monitor the child, get a good X-ray, and then you see how the things are going. So optimal lung volume is determined by increasing the SpO2, allowing your FiO2 to be weaned off. So basically, lung oxygenation is the most important parameter to know about the recruitment strategy. So if you're able to wean off your FiO2 on HFO, it means that your lung recruitment strategy is working well. Second thing, what we can do is on the bedside after clinical monitoring would be to get an X-ray done, and you see how the lung expansion looks in the X-ray. Our target would be to go to 8.5, 9 spaces on the X-ray with less infiltration. This is what our target would be for a good oxygenation. So try reducing your FiO2 and then get an X-ray done, and you see how your lung expansion looks on the chest radiograph. Maintain the mid airway pressure and try weaning off the FiO2 gradually as per the condition of the child. So as I told you, you start with a MAP, which is 2 to 3 centimeter higher than the conventional. Start recruiting, gradually go until you get a good saturation. Try bringing down once your saturation is not improving, and then you try to find out at what level your patient is again desaturating. Once you are aware of that, this is the closing pressure, this is the de-recruitment pressure, and then again you start recruiting, and then you come here, you do not go to less than this when your patient was desaturating. This is how the recruitment strategy works. It's a very good article, which I think I would suggest everyone to read about lung oxygenation by Dr. Van Kamp, which shows you how to recruit the lungs on the HFO. So before recruitment, you can see this X-ray a collapsed lung, and after recruitment and giving that cycle whole completely, you can see an X-ray. You can see a good expansion of the lung. Well, you can see good spaces, the infiltration are less. So it is not something which will occur very fast in 10 minutes or 15 minutes, but as per the disease condition, as per the starting of high frequency, if there is a significant damage to the lungs, then the recruitment process might take few hours also. If you're starting it quite early in the disease, then the recruitment process will take less time and you will be able to recruit the lung in earlier. Another way to recruit is by doing sustained inflation. Sustained inflation is basically giving a map 2 to 3 above the baseline for about 10 to 20 seconds or 40 seconds. So you're giving a sigh breath, keeping the pressures on that for a few seconds so that the alveoli which were completely collapsed, which are not opening on your mean airway pressure, they start opening up. This is one of the way to do lung recruitment. It is above the conventional mean airway pressure, what we have been using. This technique produces more rapid reinflation of the collapsed alveoli than the approach using the gradual increase in mean airway pressure, but has not been found to be of much use in the standard trials. And you have to always go for pneumothorax. If you're increasing the MAP for a higher period of time, then there is a good chance of air leak syndromes also. So for oxygenation, what you will see on clinical examination is mandatory. You have to monitor the child for good perfusion. You have to monitor for saturation. You have to monitor for your wiggles. And how to know whether your lungs are recruited or not, you have to get X-rays done. X-ray, you might be needing more X-rays as compared to conventional ventilator because the lung recruitment occurs very fast in HFO. Your target would be to get at least 8.5 spaces of expansion. If you are going over inflation, your X-ray looks hyperinflated, then try bringing down your MAP by 1 or 2 accordingly. One should be able to wean off the FiO2 to less than at least 60% within the first few hours of life. If you're unable to wean off the FiO2, then always think about some other coexistent condition also. Try your recruitment maneuver by the sustained inflation or gradual increase in the mean airway pressure according to the X-ray. And always try to find out other causes of hypoxia, whether there is pulmonary hypertension, whether there is sepsis, whether there is some other issue. Try to find out those things. Always ensure that your intravascular volume is okay, because with high mean airway pressure, with high interthoracic pressure, it can decrease the venous rate and it can decrease the cardiac preload. So always try to give fluids accordingly, and you might need inotropes accordingly. Pulse oximetry is mandatory, and you have to wean off the FiO2 seeing the pulse oximeter. You cannot do blood gases very frequently, but monitor your saturation and trend of saturation and decrease the FiO2 accordingly. Coming down to ventilation, there are 2 knobs on the machine. One is the frequency, which we usually do not touch, and one is the amplitude. Amplitude is basically the amount of wiggle what you are seeing. It is the movement of the piston, which brings about the changes in the tidal volume. So what is the tidal volume is controlled by the force of the oscillatory pressure that I showed you. And VTHF correlates directly to the carbon dioxide washout. VTHF is basically the tidal volume on the high frequency. Frequency is measured in hertz. We start from 3 to 15, and we don't change the frequency very frequently. So you see here that the stroke volume or the tidal volume, which is generated in the high frequency ventilator, with increase in amplitude, the tidal volume increases. So very clear, tidal volume increases, your CO2 washout increases. So whenever there is CO2 retention, you will want to increase the amplitude to wash out the CO2. So this is very simple. For frequency, it is almost opposite of what we do on the conventional ventilator. On a HFO, if you decrease the frequency, you're putting it frequency from 12 to 10, your time, this I time, E time increases. With this increase in time, there is increase in the tidal volume. So basically, if you want to have CO2 washout, then you might have to decrease the frequency, which is opposite to what we do on the conventional ventilator. Carbon dioxide levels are a correlation of the tidal volume. And now there are newer machines which monitor the tidal volumes. So we'll talk about that. The tidal volumes, and you get the value of dCO2, which is a coefficient of carbon dioxide. It is frequency multiplied by tidal volume square. In conventional, what minute ventilation is rate by tidal volume, but in HFO, it is frequency by tidal volume square. So even a smaller change in the tidal volume will lead to a significant change in the carbon dioxide levels. How do we start with the amplitude? The amplitude is basically the power of the oscillator, and the degree of deflection of the piston determines the tidal volume, as I told you. It is seen clinically as the wiggle. What you saw in the wiggle, there are vibrations of the chest, which we have to monitor very closely. The circuit, even for the HFO, is a rigid circuit. It is not the conventional circuit what we use. So the dampening of the power is not there. So we have to use a very rigid circuit. Even for the other ventilators like the Fabian and the SLE, they have a rigid circuit of for the high frequency. Wiggle with different machines is different, and you have to know your machine very clearly. The wiggles on the Sensormatics is different as compared to the wiggles on the Fabian. So you have to understand and you have to know your machine very well. There is no tidal volume monitoring in the Sensormatics. So it is a bull. There is nothing what you can monitor. What you can monitor is only clinically the vibrations, and you can do the blood gases to see the AB, the carbon dioxide levels and the PO2. The wiggle factor, as I showed you, you have to reassess after each and every positional change. I mean, is there the wiggles are coming both the sides equally, or there is a unilateral decrease or increase in the wiggle? It can be related to some pulmonary compliance of secretions, ET disconnection or obstruction or bronchospasm. You have to monitor those very clearly. Amplitude is according to the machine what you're using. Start with some basic amplitude so that you are getting a good wiggle. You are seeing the wiggles up till the upper part of the lower part of the groin. This is our clinical adjustment. And then according to the wiggles and according to the ABG, which shows the carbon dioxide levels, you have to increase or decrease the amplitude accordingly. Frequency settings, smaller the baby, higher the frequency. So for smaller preterms, 1 kilo or less than that, use higher frequency, 12 to 15. For term babies, you can use a frequency of 8 to 10. We usually do not change the frequency much because the carbon dioxide levels are mainly monitored and are basically done by the amplitude levels only. If needed, we can change the frequency in a step of 1 or 2. So if there is problem in ventilation, what you will do first? You will first increase the ventilation, increase the amplitude. So by increasing the amplitude, there will be CO2 elimination. And then if with that you're on the maximum setting, not improving, then you will think about considering decreasing the frequency. I time 1:2 is what most of the ventilators and most of the people do. This is stable. Hardly you will try doing a 1:1 ratio when there is severe CO2 retention. But we don't suggest, so we don't want to change the things for most of the times. So clinically, if you see you have poor oxygenation, poor lung aeration, then what you will do is lung recruitment, increase the mean airway pressures or SI when needed, and then decrease after improvement. Second, inadequate oxygenation plus hypercarbia. There is CO2 retention also. And on an X-ray, you are seeing that there is overexpansion. Overexpansion means 9.5 spaces. Then what you will do, you'll start decreasing the mean airway pressure. You are in the hyperinflation zone. And then you repeat the X-rays. Hypercarbia without lung expansion. Your lungs are quite okay. Then you will only try to change the amplitude levels. Hypocarbia. Hyperoxia by decreasing.
Ready time to
Sedation and analgesia as for the conventional ventilator. You do not paralyze the most of the patients. Neuromuscular blockade is rarely required. There is a good synchrony between the patient and the oscillations. So you can start doing that. Auscultation will be difficult because of the vibrations what you'll be seeing. So temporarily you might have to stop the oscillator and you can auscultate for heart sounds. But if you can, if you are listening to the oscillations, if you are listening to the oscillation, they are asymmetrical, then you have to think about issues related to the tube blockage or secretions or some pneumothorax has occurred. So you have to monitor that. Chest X-rays, as I told you, you will need to do more chest X-rays as compared to the conventional. Usually after any major changes, after 20-30 minutes of that, you get an X-ray, and at least 12 to 24 hours, you'll get one X-ray. You might need more X-rays when there is an acute deterioration or there is a there is a problem in the monitoring, like there is oscillations are visible on one side, wiggles are on one side, then you might have to get an X-ray done. ABG monitoring is important because carbon dioxide levels very drastically come down on a HFO. So you have to monitor the blood gas and monitor the carbon dioxide levels on that. A transcutaneous carbon dioxide monitoring is far better if it is possible, but most of the units do not have that. So we usually monitor the blood gases and monitor the PCO2 accordingly. As I told you, in newer ventilators, you have the carbon dioxide monitoring because you have the tidal volume monitoring. And so the DCO2 value you get which is a carbon dioxide diffusion coefficient. It can be monitored. It is not direct correlation of the carbon dioxide levels in the blood, but it will help to give you a trend what DCOT you were on, and then within the next few hours, if whether it is increasing, decreasing, you will know about what is the trend of carbon dioxide going on inside. Suctioning de-recruits the lungs, so try not to suction much, and if needed, then you might have to do a recruitment maneuver following suctioning. A closed suction, if it is available, it should be very good so that your pressure is not lost during that process of suctioning. Weaning, principle of weaning would be once your lungs are okay, your lungs are well recruited, you're on minimum FiO2 and minimum pressures, you will try to wean off. So definition would be when your FiO2 of less than 30%, you come down to map of 7 to 8, they will try to wean off the patient from the ventilator. For bigger babies, you directly extubate from the high frequency to good oxygen or oxygen, whatever is needed. For smaller babies, you may shift them to the CPAP. There was a trend to wean off the pressures to patients from HFO to conventional ventilator. But I think if your team is well experienced enough, then you can directly extubate to the non-invasive modes of ventilation also. Complications related to HFO, there is a very significant higher intrathoracic pressure. So you have to monitor for tidal volumes. You have to monitor for venous return and perfusion. You might need volumes and you might need inotropic support. The mean airway pressure, which was fine at 6 p.m. in the evening, can become in the hyperinflation zone at 9 p.m. You can be develop a pneumothorax. So be very, very watchful. Pneumothorax is an important complication. You have to monitor the child. So you might need more frequent X-rays also in high frequency ventilator. Displacement or migration of the tube is a rare possibility. Bronchospasm, acute airway obstruction because of the mucus plugging, because of the vibrations. You need a very good humidification. Your humidifier has to work very well on a HFO ventilator. Necrotizing tracheobronchitis when it has been used for a very prolonged period of time. Increase in IVH and PVL was there in the older trials, but not seen in the recent machines, and with a good lung recruitment strategy now. Newer machines are, as I told you, that you are monitoring the volumes now, and now we are, as Dr. Archana told, volume guarantee along with high frequencies is a newer mode which is available now in some ventilators. So you target your volumes and then you fix up your volume guarantee. The amplitude, the machine will decide on its own like it does in the conventional volume guarantee mode. The leaks has to be, leaks can be a problem, so you have to monitor that and you need a good sensor for it. Clinical management strategies, there are two main types of disorders. One are the diffuse homogeneous disease, like the symmetrical lung disease, like the RDS, severe pneumonia, ARDS, hemorrhage. And there are the non-homogeneous disease, which is asymmetrical disease, like Apache infiltrated one side, hyperinflation on other side. These are these asymmetrical disease. Lung hypoplasia, like a low, like congenital diaphragmatic hernias or pulmonary hypoplasia syndromes, where your strategy would be to use a low volume strategy. Most of the time they use the high volume strategy, and air leak syndromes and hypoplasia will use the low volume strategy. So what are the indications when we shift to HFO? Either it could be, these are the three ways how we do it. Most of the time when the HFO was started in 90s and the early 2000s, people used to use it very, very late, when most of the damage in the lungs was done. With conventional ventilators, they did not manage, the saturations were not improving, and then shifted to HFO. Most of the ventilation-induced lung damage has been done, and then the results of HFO are not very encouraging. Second would be a proactive or an early rescue strategy. As I showed you, that the chances of ventilation-induced lung injury is high because of need of higher pressures and higher volumes. And if you shift at that point of time to HFO, then the results can be good. And this is where the role lies at this point of time, where everyone should be aware of the role of HFO as a lung protective ventilation strategy. So the results are better, and the guidelines are as a map of more than 12, OI of more than 12 to 15, FiO2 more than 60%. As I told you, the gestational age, if you're needing PIP more than the gestation of the child, you can shift him to HFO. This is a rough calculation. Anytime blood gases are not improving, along with your maximum changes, also high frequency would work. Some units in the world are there which are using early intervention. Early intervention means if you need to ventilate, then you put them on the HFO. You do not use conventional ventilator at all. If you're needing invasive ventilation, after failing of non-invasive, then you put them on the invasive ventilator. So this is an early intervention. Good number of trials, good number of evidences and experiences is that this strategy do does work very well as compared to conventional ventilator. So some few evidences, I have just 5 minutes now. So comparing conventional versus the HFO, the Cochrane database shows that. Yeah. So if you're using it for preterm RDS, then if you're using a low rate CMA, means not recruiting the lungs properly, then HFO is better. But if you're using with the optimum lung ventilation strategy, you can see the results are almost optimum in both the things. Conventional or HFO, it is not the machine, it is basically your ventilation strategy which is useful, which is shown in the meta-analysis also. If you see death or BPD, not much difference, but the trend towards HFO, BPD at 28-30 days, trends favoring little bit of HFO. Pulmonary airlics are more in HFO, so it favors conventional ventilator. Gross airlics, no much difference. IVH, not much difference. But if you see ROP, then there is a significant advantage in HFO for ROP stage 2 or greater. So overall, high frequency is better. A short note about high frequency nasal HFO. It's a newer mode. When we talk about non-invasive modes about HFNC and CPAP, nasal HFO is also one mode which we have been using. More evidence is needed to compare it with other non-invasive devices. We are using it in early RDS also, in post-extubation settings also, and still more trials are needed for it. So in high frequency, there is no clear high frequency standard of practice. What you have to do is that you have to know the disease pathophysiology and to try application of your knowledge and of your machine to that. There is significant variability in the application of HFO in different units. In our units, we may start on early HFO in first few hours immediately. In some units, they start quite late when the damage has been done. So there are a lot of different application variability in different units. Which is the best machine is yet to be identified. Whatever machine you are confident enough in using, you know the machine well, you start using it. Our experience of high frequency has been very exciting. In last about more than about 18 years, we have been using more than 1,000 babies, and we are still learning. Every baby on the HF is still giving us some or the other intent, teaching us something. We have used the sensor medics, the SLE, the Fabian, and I am little bit more biased towards the sensor medics. But now the newer machines are coming up with good tidal volume monitoring, which has become easy, and so the need for blood gases has come down significantly. It's safe and easy to use. All our long-term follow-ups are also quite good. First is to learn the machine and the art of monitoring the patient or HFO. Your staff has to know what are the wiggles, how were the wiggles, how are the auscultation. Everything is very, very important. Very useful for diffuse hazy lungs at any stage of disease. Severe RDS, severe pneumonia at any stage of time, HFO works quite well. High frequency with nitric works very well in severe pulmonary hypertension and MS patients. It is an excellent machine for removing carbon dioxide, which we cannot do on conventional many of the when we got stuck in the conventional ventilator. A very powerful machine. If you do not monitor carbon dioxide and air leak, then it can lead to havoc. Our experience shows that the days on ventilation is less as compared to conventional, and the overall cost comes down. The earlier you start, the better are the results. And basically, it's our Brahmastra, it saves lives. We get a lot of babies from other peripheries and from other pediatricians because of the high frequency that we are using it in a better way. So basically, you have to train your team, and the art of HFO is important. At the end of the day, we all have to know that what we are dealing is a small newborn. Whichever method of ventilation we use, it is more important that the clinical observation and the bedside vigilance, timely action, and the human touch and the tender care cannot be replaced by any technology. So our concept of ventilation of neonatology is first do not do any harm, primum non nocere, and this stays for any patient, any ventilated patient. So I would end up my talk here. Thank you very much.
Any questions? Sachin, very well done. The last slide says it all, that it is not the machine, it is the man behind machine, and we need to treat babies as a whole and not as a single baby every time. Nutrition, temperature, positioning, suctioning, asepsis, so many things goes behind ventilating a sick babies, and your experience is tremendous in managing HFE that we know. Very important part that he mentioned was that opening of the lung, like you get to some pressure and then keep on increasing pressure till you get a level where you can come down on your SpO2. Once we finish your talk, can you mention that article in the chat box so people can go through the article and can read how to adjust those things? You mentioned, but one comes article
Yeah.
somewhere in
Yeah,
that.
I'll put up the link to the article in the chat box so that you can all access the article.
Yeah.
It's a open access article, and I wish that everyone should read this. Over ventilating, you should read this article.
And believe me, this is a very old article. In fact, it's something like 1992. I read it.
Yes, it is. It is 30 years old article, but it is a gold standard article for high frequency. You read it and you understand it, then you will never forget it. My practice is based on this article which I read before about 20 years.
This article
I'm
goes
putting a link on that. I'm putting that on.
Yeah, this is mainly about the pepophobia and pepophilia in the article, that you just
Yes.
keep on increasing your anex pressure to a level where oxygen can be weaned. But the way it has been discussed is something great. So everyone need to go through that. Anyway, any questions I don't see in chat box also. So this is the time where I can invite my friend Dr. Srinivas Murthy. He's from Paramata Group of Hospital from Hyderabad. He did his MD pediatrics from Jipmer and went on to get DM from BJ Chandigarh. Introducing him to this August audience is like introducing Mahatma Gandhi to citizen of India. He has been great teacher, a great friend, very kind-hearted, always ready to help, and you will see him off and on in so many places where the academics are happening and the real teaching is happening. Always eager to help. He had, to his credit, he has got many research publications, some basic research on CPAP and non-invasive ventilation. His own research about humidification keeps on going. And I must say that he is the one, I mean, both of us did so many ventilation workshops all across the country, along with our mentor, Professor Ashok Devrari, Praveen Kumar, and all those group. But he is the one of the person who has pioneered non-invasive ventilation in this country, contributed to so many non-government organizations setting up the CPAP units or non-invasive ventilation units in the country. And if I keep on discussing about his achievements, it is going to take very long. I'm sorry, Murki, I can't discuss it in a length, but I must appreciate that at the last moment he accepted this invitation to take this talk. I happened to call him Monday morning and said that you need to do that. At the first go, he said, I'll do it. So that's the friendship that we carry with each other. Thank you very much, Dr. Murki, and the floor is yours.
Thank you, Ashish, and thank you for all those bubbly words. I don't deserve much of them. Yeah, so thank you. And obviously, you asked something which I can't refuse. So because you said I have to speak on CPAP, and I can't refuse. If somebody asks me to CPAP, then I think it's my job to ensure that I teach CPAP to many people. So although Ashish said I have to speak on CPAP, but I thought I'll speak more on bubble CPAP because I think that's where my heart is, and I feel we all need to work on more bubble CPAP rather than on CPAP of any mode. The other thing is I think I should thank Sachin because I think he has put HFOV before CPAP. And I can tell you that CPAP is a miniature HFOV. CPAP has the oxygen component of HFOV. So as Sachin said, there are only two knobs which are important in HFOV for oxygenation, that is MAP and FiO2. These are the only two knobs which we use in CPAP also, because we are talking only about oxygenation. And ventilation is automatically controlled by the baby. So that's why we use CPAP only for babies who have good respiratory efforts and not for babies who have poor respiratory efforts. So I think, Sachin, thank you for at least putting the introduction onto CPAP in a much larger scale. And so this, I want a small disclaimer that I'm going to show you some one device which is innovated by us that marks a precise air oxygen flow. So through the device, I may be showing the device at the in between the slides. So thank you, Ashish, for all the coordination. So my objectives are to tell you when to use bubble CPAP, how to use it, how do we start, how do we monitor, how do we wean, and when do we say we have failed on CPAP. And how do we improve? Because every unit needs to work on improving the efficacy so that our failure rates will decrease on CPAP. So every time we work on CPAP, for the last 20 years, we have been learning CPAP, and then we'll continue to learn because there's something new which we learn every time we work on bubble CPAP or CPAP. I'll also tell you some learning options for everybody who is attending this class. So let's start with this case. This is a typical 30-weeker, 1.35 girl child, born by preterm delivery. 1 dose of steroid was given before 6 hours prior to delivery. And that's incomplete steroid coverage. And we know that this baby at 30 weeks, 1.5 with incomplete steroid is likely to have RDS. So this baby was born by C-section. There was no asphyxia. Baby was breathing well, but he has significant distress at birth. So the referral doctor felt that the baby needs CPAP support. So the baby was shifted to a tertiary NICU, which the baby was shifted on nasal oxygen for 4 hours. So the point which I wanted to make here is that the later the baby comes to the NICU for CPAP, the more effort we have to put, or the more will be the failure rate. If CPAP is available in the place where it was baby was born, it would have been much more easier because you will require lesser CPAP and lesser surfactant and lesser need for ventilation if you start CPAP in the delivery room or very early in the stage of respiratory distress. So this baby at admission to the NICU, the temperature was mildly hypothermic, cold stress was there. There is a significant distress, 7/10. Now, many people feel that if the baby has anything more than 6 or 7, you have to ventilate. So it's not the question of severity of distress that tells you whether you need to CPAP or ventilation. It is the respiratory efforts. If the efforts are there, even if it's 9/10, we will give a chance of CPAP for the baby rather than going on ventilation. So the minimum score beyond which we think of CPAP, especially in a baby like this, is 3. So if your SA score is more than 3/10, that is a candidate for CPAP and not for oxygen. So this baby's saturation at admission was 93% on nasal oxygen. So although baby is oxygenating well, but he is doing this at the cost of work of breathing. So our aim is to decrease this work of breathing, and that's why although baby saturations are in the acceptable range, this baby is a candidate for CPAP. CPAP is to decrease the work of breathing, open up the lungs, keep the lung at FRC or optimal FRC, and to ensure that the saturations are well maintained with low FiO2 requirement. So this same baby, 30-weeker, you can see here, the baby is having respiratory distress. So you can see that the upper chest, there is some amount of seesaw. The abdomen is moving up and chest is caving inside. Lower chest, that is the chest below the mid-axillary line. You can see some retraction, but not reaching up the axilla. On the sternum, you can see there are sternal retractions. And I'm sure all of us can see the nasal flaring and the grunting. You can hear the grunting. So you add up this, the baby almost has a score of 7 or 8/10. So that's what I said, that if the baby is so severe also, this is a candidate for CPAP and not for ventilation. Because he has good efforts, increased work of breathing, but good efforts. So this is a candidate for CPAP. And since it's less than 35 weeks with respiratory distress and SA score is more than 3, this baby, although maintaining saturation and oxygen, is a candidate for CPAP. And this is what is called rescue CPAP. So any baby with respiratory distress in the labor room, if the SA score is more than 3, he is a candidate for CPAP, especially when the baby is less than 35 weeks. Those babies who are 35 weeks and above, we will start CPAP as rescue when the SA score is more than 5. So preterm SA score is less than 5, and term or late preterm, the SA score we take is more than 5. So here you had a baby who is less than 35 weeks and has a score 7/10. So is an ideal candidate for CPAP. So what are the other respiratory support you think you can give for this baby? Maybe one of you or two of you can write in the chat box. Is the CPAP only answer for this baby, or we can do something else? So maybe I would have listened to a different opinion from Sachin, because Sachin is a favorite of HFOV. So maybe some of you can write in the chat box what you would do apart from CPAP. So although I would say all would give an answer of CPAP, but there are new options available for some of these babies.
No answer yet.
Okay, so I hope they're all listening. So the other things one can think of is nasal IMV. So if you have a lot of ventilators which are lying free and vacant in the NICU, and you have a lot of doctors to take care, and nursing personnel is too much in the NICU, so they can use nasal IMV, or nowadays we are thinking of even nasal HFOV as a mode of respiratory support, so that you can decrease the failure rates. But for us, the gold standard is CPAP, and the gold standard is bubble CPAP. How do we give this CPAP, and what all we monitor is what we'll learn in the next few slides. So this baby is less than 35 weeks. He has a distress score of more than 3. And so the support I would suggest is CPAP, mostly bubble CPAP. So the other things, so all babies less than 35 and weight less than 2 kgs, if you have CSS score more than 3, they are candidates for CPAP. There are other indications for using CPAP is post-extubation, which Sachin has slightly highlighted. Post-extubation for HFOV also we can think of CPAP, or even conventional ventilation also we can think of CPAP. The other indications are when the baby has recurrent apneas, not able to maintain saturations with stimulus or with minimal oxygen, we will try to go on to CPAP even after caffeine. So how do we give CPAP or bubble CPAP? These are the mandatory things you need. You need pressurized air, you need pressurized oxygen, either central oxygen or a cylinder oxygen. Then you need a blender. So you need the connection for air oxygen. So you have an air connector, you have oxygen connector, you have a blender, and then you need a flow meter. So flows are the things which will generate pressures, and you need flows to generate pressure in the circuit and pressure in the lungs. And one very important thing, whether it is for HFOV or conventional or for CPAP, you need a good humidifier, which is able to deliver the gas at nose at 37 degrees and 100% humidity. And the other important thing is a pressure generator, and that is a bubble chamber in a bubble CPAP, or a flow driver CPAP. You have a device at the nose, which is called something like a Ben-Minister device, where the pressures are generated because of an obstruction at the nose. But bubble CPAP, the pressures are generated because of the bubble chamber. So these are the minimum mandatory things you need to start CPAP in your unit. So you can use a bubble CPAP, and I said that you can also use a ventilator for CPAP, and that will be like not the very cost-effective method of using CPAP. But apart from the machine, you also need to connect the machine to the baby. You need a non-invasive interface, and that interface could be a prongs, binasal prongs like Hudson prong, or a mask like Traeger or other masks. And recently, we have been very comfortable in using Ram's cannula for providing CPAP for most of our babies. And there is one caution which I want to tell all of you is when you're using Ram's cannula, if you want to give a pressure of 5, you have to use the set pressure of 6. So your bubble chamber should be set at 6 if you want to give a pressure of 5. But all other interfaces, you can use the same set to deliver the same pressure. But Ram's delivers pressure by 1 centimeter less than what you set. So how do we set the knobs? As I said, CPAP is only for oxygenation. It has very little to do with CO2 removal, because CO2 removal happens naturally with the baby's respiratory efforts. So there are only 2-3 knobs which we need. CPAP or the MAP knob. MAP in HFOV is equivalent to CPAP in CPAP machine, and FiO2 is same as FiO2. And to generate the pressure of CPAP, you need flows. So flows is almost fixed of 5 liters per minute in most of the bubble CPAPs, because the pressure required is 5 to 8 or 5 to 9 in most of our CPAP machines. So our flow of 5 liters is quite sufficient for generating that pressure. So we normally keep the flow as 5 liters constant. Like a ventilator flow, we keep 6 to 8 liters constant. In HFOV, flow is automatically set at 15 liters per minute. Like in CPAP, flow is fixed. So you have only 2 things to change, that is the pressure and FiO2. So how do we change the FiO2 and how do we change the pressure is what we need to learn. And for that, I think I want to recap Sachin's lecture again, that our aim should be to open the lung. First, open the lung and then give oxygen, so we'll get the best bed dividends. So how do we know that we have opened the lung? Sachin helped us to say that you can use X-ray, but in CPAP, you can do much more easier method, like that if the lung is open, your retractions will come down. Because we are talking about a baby who have atelectasis. If atelectasis is improved, if the lungs is recruited well, your recessions or retractions will come down. Your Silverman-Anderson score will come down. So once your lungs are well recruited, you will get decreased retractions. So when you're using CPAP, you can keep on increasing till your retractions come down. And once your retractions are come down, and if the baby is still hypoxic, then you can increase your FiO2. So remember the concept of open lung. And the way to open lung is use pressure. So first use pressure to give oxygenation and then use FiO2. So these are the only 3 knobs which we have. And how do we know that these 3 knobs are, how do we set these 3 knobs for the flow? So how do you know your flow of 5 is adequate for this baby? So if you have bubbles like this, continuous bubbling is happening in the bubble chamber, then you know that your flow of 5 liters is quite sufficient. But if the flow of 5 is not sufficient to bubble in the bubble chamber, either you need to increase the flow from 6 to 7, or more importantly, you have to look for leaks in the circuit at the interface or at the mouth. So most people feel that you have to close the mouth to get the bubbles. Please never do that. Most of the babies, this is not required. All that you have to do is developmental supportive care, putting a orogastric tube, soothing the baby, doing developmental supportive care, nesting the baby, feeding the baby, changing the diapers. These are the things you need to see that you don't have to increase the flow, but you can decrease the leaks by doing a developmental supportive care. And still after that, if the baby is still not bubbling, then you can, or bubbling is still not happening, you can increase the flow from 5 to 6. But otherwise, from our own practical experience, 5 liters flow is sufficient for most of the babies. Now, how do you know your pressure? You start with a pressure of 5 and 5 liters per minute of flow. But how do you know your pressure is adequate or not? For that, you need to look at these recessions. So look at this baby. He started on a pressure of 5. And if for the same baby, and if you see some minimal recessions like that, you know that your pressure is quite adequate for this baby. But you continue to have intercostal retractions or subcostal retractions, and you have sternal retractions, or grunting is still happening, then you need to increase the pressure from 5 to 6 or 6 to 7. So one way is your retraction should come down. Your SA score should come down when you're using CPAP. The second thing is, okay, your retractions have come down, but still oxygenation is not good. So if retractions are there, you keep on increasing the pressure, still your oxygenation is between 91 to 95%. Once your retractions have come down, but saturations are still between less than 91, you can increase your FiO2, but you always start with 30%. And once your retractions have come down, once your pressure is optimized, if your oxygenation is still below 90%, you increase FiO2 from 30 to 35 and 35 to 40 to a maximum of 60%. So overall, to tell you, when you are having hypoxia, that is saturation is less than 90%, and baby showing that his lungs are still not open, that is recessions are still not still there. So what you need to do is keep increasing the pressure from 5 to 6, 6 to 7, 7 to 8, till you get a decrease in SA score. So once your SA score is decreased and once your lung is optimized, then if hypoxia is still there, you increase FiO2. So if saturations are less than 90% and your SA score is 3 or less than 3, then you keep on increasing the FiO2 from 30 to 35 in steps of 5 till a maximum of 60%, so that you get a good saturation of 91 to 95%. So flow is for bubblings, pressure is for retractions, and saturation is for FiO2 is for saturations after taking care of retractions. So if you go in that order, I think you will be able to do successful CPAP in most of the babies. So once you have good saturations, around 95, 94, consistently baby is maintaining, that means your lungs are open, your gas is going into the lungs, and saturations are well maintained. So if saturations are well maintained, and if the baby is on a high FiO2 and high pressure, so our aim should be to keep the lungs open. So you come down on the FiO2, say is on 50%, 60% FiO2 and a pressure of 7. So you keep coming down on the FiO2 from 60 to 55, 55 to 50 to as low as 30%. So what have we started? We come down on the FiO2 to 30%, and then there are no retractions, keep coming down from 7 to 6 and 6 to 5. So once you are on 5 and FiO2 30%, subsequently, you can come down on the FiO2 from 30 to 25% and pressure from 5 to 4. At this point of time, you can think of shifting the baby from CPAP to HFNC or CPAP to room air. So which babies will shift to HFNC and which babies you will shift to room air? So babies who are more than 1 kg, you will start shifting to HFNC. But if the babies are more than 1.5 or more than 2 kg, babies can be straight away shifted to room air, especially if he's maintaining on 4 of pressure and FiO2 less than 25%. So in this infant, the baby was started on a pressure of 5, FiO2 30%, and flow of 5 liters. The Over the next 24 hours, the SI score reduced to 3 by 10. FiO2 was still 30% and flow was 5 liters per minute. And over the next 12 hours, that is after 36 hours after CPAP, so you can see that the baby's score has almost become 1 to 2 or normalized. FiO2 was further dropped to 25%, and then CPAP was dropped to 4, and then flow was maintained as 5 liters. So at this point of time, what is the next plan? The next plan will be either start room air or HFNC. Since this baby is less than 1.5, we can start shifting on to HFNC because he still requires around 25% FiO2. So apart from CPAP, the other adjuvants you should always think of is starting caffeine for babies less than 1250 grams and starting minimal enteral nutrition. All babies on CPAP, if there is no contraindication, they should be started on feeds as early as possible, as aggressively as possible. So most of the time you can put him on full feeds if the baby is more than 1 kg. Less than 1 kg, you can start at 2 ml 4 hourly or 6 hourly, and then keep increasing so that by 5 to 7 days, the baby can come almost to full feeds. So the baby was started on HFNC. Since the baby was more than 1 kg, we started on HFNC. And if you're starting an HFNC, you start with 5 liters per minute of flow. FiO2 same as that of a CPAP. Now, so subsequently, you keep coming down the flows from 5 to 4, 4 to 3, 3 to 2, and you can come down on FiO2 to 21%. Once is 21 flow of 2, you can remove the baby from HFNC to room air. So less than 1 kg, sometimes you may not be able to extubate remove the baby from FiO2 25%. So in those conditions, you will have to come down to FiO2 21% before you think of shifting the baby to room air. So the same baby, let us imagine this different scenario. We have seen that a baby, 30-weeker baby who was started on CPAP, caffeine, feeding was started, and the baby improved dramatically. Although he came late at 4 hours, but the baby improved dramatically just with CPAP by just keeping pressure of 5 FiO2 30%. Has shown significant improvement. We could come out of CPAP by about 36 hours. Now let's examine the same baby in a different scenario. So let's assume that same baby started on bubble CPAP with binasal prongs, pressure of 5, FiO2 30%, and flow of 5 liters. But over the next 4 hours, what happened is the SI score continued to remove at it has come down from 7 to 6, but continued to be more than 3 per 10. So, and the saturations were borderline. So what do we do now? So we have two choices. We want to open the lung. So you can go up from pressure from 5 to 6, 6 to 7, or 7 to 8. Some people go up to 8 or more than 8 also, but most of us are comfortable up to 8. So we can go, this baby, since the retractions are still there and is still hypoxia, we can go up on 5 to 6, 6 to 6, 6 to 7. And after going on 7, if the saturations are still low, although retractions have decreased a little bit, but if saturation is still low, you can keep on increasing the FiO2 to a maximum of 60%. But you can keep the flow at 5 liters per minute as long as bubbles are there in the bubble chamber. So what is the plan now? So this baby, we have come to a stage of pressure of 7, FiO2 60%, and flow of 5 liters. So what should we do now? Now there is another option for us. So if the same baby on a pressure of 5, 30% FiO2, if retractions are not coming down, instead of increasing pressure, we can open the lung by other method, and that is by using surfactant. So you can use surfactant here because you know that this baby has come late to us and he has not received surfactant. He was not steroid covered. So this baby is likely to have RDS. So those babies on CPAP or 5 or 6 with FiO2 30% or more, those are the candidates for giving surfactant. So instead of going from pressure to 5 to 6, you could have easily given a surfactant and continue the baby on same settings. So other method is keep on increasing the pressure till your retractions are come down or till you optimize the lung volume. So, but before you think of that CPAP is not working or you want to increase the pressure or give surfactant, you need to see whether your CPAP is working or not. So first look at the bubbles in the bubble chamber. If bubbles are there, your flow is adequate, there are no leaks. Then you hear for bubbles in the chest, you auscultate the chest. If you are able to hear the chest bubbles, that means the pressure is reaching the lung. So that means your pressure is reaching the lungs, and still if retractions are not coming, then there is a scope for increasing pressure or giving surfactant. Then you also look for humidification, because humidification is the crux of CPAP or respiratory support. So there should not be any condensation in the inspiratory limb, and there could be, that means if there is no condensation in the inspirator limb and the temperature on the humidifier displays 37, that means humidification is appropriate. And also look for the seal and the interface is well fixed or not, so that the baby is not crying or uncomfortable. You give the developmental supportive care, make the baby quiet so the pressure reaches the lung. So you need to have a good interface. And at the same time, if things are not working, always get an X-ray to see that whether you are dealing with the same disease of RDS or something else. If it's RDS, you can even give surfactant. But if it's something like PPHN, or if there is a heart disease or something else, you need to work upon the X-ray. The other thing why you want to do X-ray is also to know that whether your lung volume is appropriate or not. Sachin told us that we need 9 spaces in HFOV, but in CPAP, we require about 6 to 8 spaces. And that's quite sufficient for us to see that the lung recruitment is adequate. So here you can see this baby's lung is shown well inflated, but there is bilateral reticuloglandularity and there is air bronchogram. So this is a classical RDS. So instead of going for pressure, you can go up on the surfactant. So put the baby on CPAP, give surfactant, continue to maintain same pressure. Most of these babies will do very well. So this baby was given intubated, given surfactant, extubated back to CPAP. And other supportive care also was continued, like relieving pain, nesting, oral coating of colostrum, gavage feeding, maintaining temperature, maintaining sugars, correcting calcium, anemia, polycythemia, fluid boluses or fluid corrections, inotrope use optimized. So all this should be done while the baby is on CPAP so that success of CPAP is improved. And over the next 12 hours, this baby's score has become 3/10. Saturation was 94%. FiO2 was reduced to 30% in step 5%. And CPAP was decreased then, was already at 5% from 7. So first FiO2 was reduced and then CPAP was reduced from 7 to 5. So when you're going up, go up on the pressure. When you're coming down, come up on the FiO2 first. So, but if the baby continues to be on CPAP of 8 and pressure of FiO2 60%, still retractions are there, still hypoxia is there, then we say that baby's failed CPAP. But before you say baby has failed CPAP, again go through the checklist. Ensure that bubbling is there, bubbling is seen, bubbling is heard, and humidification is appropriate before you say that your CPAP has failed. And also ensure that you're given surfactant before saying that your baby needs to go on NIV or other modes of ventilation. So what are the methods to improve the efficacy? Use the correct interface, use bubble CPAP machine. Compared to other machines, bubble is better. Ensure appropriate humidification. The gas should come to the nose at 37 with 100% humidity. Monitor the baby, the interface, and the machine. Simultaneously, all three should be monitored. So you need a wonderful nurse who can take care of all the three. Simplify the setting. So flow is fixed, pressure is for retractions, and saturation is for FiO2. Sorry, FiO2 is for saturation after correcting retractions. And always think of troubleshoot, use of adjuvants like caffeine, feeding, developmental supportive care to improve the efficacy of CPAP. And always have a backup ventilation or backup referral, because in 10 to 15% of babies, CPAP can fail, and that babies need to be shifted. So you can use any one of the interface, either a Hudson prong or a Ram's cannula or a nasal mask. All three are good. All three are fine. But for the ease of use, Ram's I feel is better. But for small babies, I feel Traeger is a good choice. So CPAP machine, you need definitely compressed air and compressed oxygen, a blender and a flow meter, humidifier and a bubble chamber. But now, instead of, if you don't have compressed air source and compressed oxygen, and you can just use a cylinder oxygen like this, and you can have a machine like Merck's TPs, which replaces a compressed air source, which replaces a blender, and which has inbuilt pressure sensor and also FiO2 sensor to measure exactly the pressures you're giving and to measure the FiO2, which you can titrate by titrating the amount of oxygen you're driving into this machine. But other things should be continued, like a good humidifier and a bubble chamber is required. So if you don't have compressed air source, if you don't have blender, and if you don't have a pressure monitoring, you can use Merck's TPs, which is an inbuilt compressor with FiO2 and pressure sensors. And always tie up with kangaroo mother care. If the baby is on long CPAP, and this modality of kangaroo care with CPAP is going to be a wonderful addition. And most of the babies are going to love both CPAP and feeding and KMC. If you can make a gel of these three, I think our job will be well done for babies with the respiratory distress. So I said, monitor the baby, monitor the interface, and monitor the machine together. So especially the interface, ensure that there is some distance between the columella and the interface. The blanching should not be too much on the nose, and the columella should not be budged. And there should be some amount of oral and nasal suction frequently. You can add saline drops. You can do a gentle massage of the nose on each shift. And for the machine, look for the bubbles in the bubble chamber, temperature on the humidifier. Ensure that the circuit is always kept below the level of the baby, and flow rate should be 5 liters per minute. So this is simple chart. I'll share this chart with Ashish and the group so that you can use this chart in your NICUs. It tells you when to start, how to initiate, and how do you go up on CPAP and FiO2, how do you do the monitoring, how do you take care of the Silverman score, what all you monitor, and there are troubleshoots, how do you take care of the troubleshoot. So this is the chart which we use in our SNCUs, and this can be a very useful addition for most of the people who want to learn and do CPAP regularly. So troubleshoot wise, if there are retractions and hypoxia, our aim should be to open the lung. So open lung means no retraction. So our aim should be open lung and then put in FiO2. So if you're not able to open lung, either there are leaks or your pressure is inadequate or there is less surfactant. So first take care of leaks, give surfactant, and then increase the pressures. If there is saturations are low, no retractions. If there are no retractions but saturation are low means that means lung is open but your FiO2 is inadequate. So keep increasing the FiO2. But if your retractions are not there, but if baby requires high oxygen, most likely baby has a heart disease or a PPHN or your blender is not working. If there is retractions and hypoxia, there is air entry is not there. That means the bubbles have not reached the chest. Bubbles are seen in the bubble chamber. That means pressure is there in the circuit, but bubbles are not heard. That means these bubbles are not going to the lungs. There is a block in the nose. This is a very useful thing because if you're able to see bubbles are not able to hear, you need to take care of the nasal interface. Either there is a block or there are secretions, you clean it. And again, remember that there should not be any condensation in the inspirator limb. For that, you need to use a good humidifier with heater wire, with water in the humidifier chamber, and ensuring that your room temperature is not very cold. And there should be some mist in the expirator limb. And then you know that your humidifier chamber is working. So this is a tool which we have used in our SNCUs. It tells you how to assess bubble CPAP in your units. And it on the bottom chart will tell you that each one of these babies. So you can assess in this chart 8 babies, whether they're getting optimal CPAP in your unit or not. So some more learning options. The best thing is to spend a week in Sachin Shah's unit or Ashish unit or some other units which are doing plenty of CPAP, or learn online. This is a preterm care package which easily enroll. You can all of you can enroll, and this has a free module on CPAP, and you can learn. You can get a certificate, or you can watch one of you can subscribe to my YouTube channel. Lot of things on ventilation and CPAP are easily available. Lot of videos on CPAP use are available, or you can buy a module on CPAP and attend a CPAP workshop which we conduct across the country. And last but not the least is always spend time in units which are doing CPAP and send your senior most nurse or your nurses to work in those units for some time so that you can learn the art and science of CPAP. Thank you.
Thank you very much, sir. A very excellent talk. And I've listened to you so many times, but every time I am still finding something newer and newer each and every time about CPAP. So it just makes me feel that still there is a lot of thing to learn from you. Listening to you and just seeing how you make CPAP so simple, and you've done it in the peripheries, in the SNCUs, and on a mass scale. So hats off to you. And it was an excellent talk as always. Ashish bhai, any?
As usual, great. Nothing more to add. We have been listening to him often and again, maybe 500 times, 600 times. And you are right, every time is something more to add. But to this August audience, I must say that we have been using Mux TPs like anything. Very good for the transport. That too, we do not have in-house labor room. So those who are transporting, we need to have FI to control. And this is the only one CPAP or the TPs where you got at least effort to sense to tell us that how much effort has been delivered. So Brahms cannula and Mux TPs will make a huge support to transporting the sick small babies. Anyone can try. Our experience has been good, and let's see. That's it. Thank you, Shas. Thanks for the great talk. So next is Biraj, Sachin.
So, inviting our next speaker, Dr. Biraj. She is a neonatologist at Akanksha Hospital at Anand. She did a fellowship in neonatology from Nirmal Hospital. She's a core neonatologist, very active member in academics, and she's fond of POCUS and Focus. And she's one of our star speakers in all the major conferences. So, Biraj, inviting you for this last talk, which is one of the most important talk, bridging between CPAP and invasive ventilation. So, if
And
something
breathing
goes wrong
between the
before
sleep.
ventilating, you can do that.
Ventilation and sleep, bridging between the ventilation and sleep.
Bridging between hard work and the good sleep.
Yes, yes.
So in short, you have got a 30 minutes to finish it off. In
Yeah.
black. Yeah.
So last talk of the day and then.
Nice to see you, OPD Pati.
हाँ सर કોને જતીન ને કીધું ને હા
જતીન મારા જતીન ઠક્કર વિરાટ ઠક્કર ધીરેન ઠક્કર અમારા બધા ઘણા મિત્રો બધા ઠક્કર ભેગા થયા છે
રઘુ
સર, જતીન છે ને ઓપડી બતાવીને ફક્ત મોઢું બતાવવા માટે જ આવ્યો છે, અત્યારે જ આવ્યો લાગે છે.
હા એ બચારો he told me to come here to if required he will chip in tomorrow also. That is what he said.
Fine, fine.
હું આવીશ સર કાલે.
આવો most welcome. Yeah, go ahead, please,
Over to you,
Biraj.
Biraj.
So is my slide visible?
Not yet. Your screen, yes, it is visible. Good, 33 slides.
So 33 slides for HFNC and 60 slides for NIMV. So I hope that I'll be able to finish it in time and I won't stop you guys before you sleep.
No, that's
Stretch you a little longer.
Yep.
And I hope that I'll be able to make you all not dozing off for another 30 minutes. So here we'll be starting regarding to another known invasive respiratory support, that is the HFNC and NIMV, after completing the CPAP of excellent talk by Dr. Murki sir. So as we all know that even a single mechanical breath can damage a baby's lung, and that is how we are shifting from invasive to non-invasive more and more. And out of those non-invasive, they are broadly categorized into constant pressure devices, that is CPAP and HFNC, out of which the CPAP has already been finished. In the variable pressure devices, that is NIPPV, BiPAP, and NHFOV. So where we set two levels of PEEP. One is the lower level of PEEP, that is PWP, and one is the upper level of PWP. So that's how that is a variable pressure devices, and constant pressure is CPAP and HFNC. So let me start with the HFNC first. So what is HFNC? So it's basically triple HFNC, that is heated, humidified, high flow nasal cannula. Why it is heated? Because it is heated near the body temperature. It is humidified up to the 100% of the relative humidity. It is given with the high flow. The flow which is more than 1 liter per minute, that is up to 2 to 8 liter per minute in newborn, is considered to be the high flow. So heated, humidified and high flow is being delivered by a conventional nasal prong kind of a devices is called the HHHFNC or H3FNC. So how it is different from the CPAP? As Murki sir has mentioned that in CPAP, the expiratory limb is being dipped out inside the water, and here we can have a generation of the PWP. Against that, in HFNC, there won't be an expiratory limb. There won't be a tight seal at the end of the nest. So that is why the HFNC is a bit different than the CPAP. HFNC can be given by the Optiflow, it can also be given by the Airvo, and it can also be given by the Vapotherm. So these are different devices by which you can give the HFNC. But why there is a need of HFNC when we have already learned about the CPAP? So studies has proven that the CPAP leads to the nasal trauma, which is less with the HFNC by 40%. It is more comfortable to handle, especially while you are giving a KMC and all those things. HFNC is definitely more comfortable compared to the CPAP. And HFNC requires less invasive monitoring and less barotrauma compared to the CPAP. And that's why the HFNC is a bit more taken in consideration. So let's understand that how does this HFNC works. So first mechanism is it helps by washing out of the CO2 from the anatomical dead space. What does it mean? What is anatomical dead space? So space in the nasal cavity, nasopharynx, and up to the alveoli, which is not being there in the gas exchange. So these are called the anatomical dead space. So when we exhale the air out, at that time, this anatomical dead space is being filled with the CO2. Once you give the oxygen, at that time, this oxygen mixed with the CO2 goes to the alveoli. And this air dead space is almost 3 times more in the newborn compared to the adult. So if you give, rather than simple low flow cannula, if you give the high velocity of the gas through this anatomical dead space, definitely it will help you out in washing out of the CO2 and help you out in better oxygenation. So that is how it helps. The second mechanism by which it works is by decreasing the airway resistance. How? Giving the high velocity of the flow would lead to the stretching of the alveoli and ultimately would lead to the increase in the diameter. So against the law physics principle, if diameter increases, resistance decreases, and that's how it helps you out in decreasing the upper airway resistance and thus reducing the work of breathing. So here we are giving a heated and humidified gas. Usually whatever gas we inhale, it is of room temperature. It is being heated up to our body temperature. It is humidified by our own body mechanisms. And this would lead to utilization of the energy. So by giving the readily conditioned gas, heated and humidified, this would lead to the decrease in the metabolic need of the body. And why this humidification is needed? Because if you give a cool that is 4 to 5 degree temperature of the oxygen, dry oxygen, then it would lead to the moisture and heat loss. This results in the thickened secretion and impaired clearance, drying of the nasal passages, mucosal injuries, slow or no mucociliary clearance, ultimately leading to reduced airway patency and compliance, compromised airway defense, patient discomfort, infection, bronchospasm, and blah, blah, blah. So that's why we should be giving, never ever give the cold oxygen. If you are giving a high flow, it is always to be heated and humidified, and that is how it also reduces the metabolic need of the body. And one of the mechanism by this, it helps in decreasing the work of breathing. The last mechanism is increasing FRC. Can it really delivers the pressure? Can HFNC delivers the PWP? Yes, it can. It's a simple, again, physics principle. If any flow is passing through the tube and if there is a resistance applied to that tube, definitely there is a generation of the pressure. So in HFNC also, there is a flow which is being obstructed and there will be a generation of the pressure. But pressure generated here is variable. It depends upon the how much flow you're using. It depends upon the how much resistance is being applied in the form of the size of the prong used in relation to the nares. And it also depends upon the leak in the systems, that is around the nares and around the prong in the nares and from the mouth. And this is the graph which depicts that how the pressure generated is variable in case of the HFNC. Here we can see that when the flow is 2 liters per minute, at that time the pressure being generated is somewhere around 3 to 3.5. And as we increases the flow, the generation of the pressure increases. Okay. But along with that, the variation in the pressure, you can see that the pressure is being varied. So variation in the pressure also increases with increasing in the flow. Here the pressure varies somewhere around 0.5 and here the pressure variation is more than 1. So this is how it provides a variable pressure, PWP. Again, the diameter of the nares. So diameter of the prongs which you are using also depends, helps in this deciding how much pressure is being generated. If the prong diameter is more, the pressure generated is high. So ideal prong diameter should be occupying less than 50% of the nares. So this is how the HFNC works. So let's see that where we can use the HFNC and what is the current, what are the current evidence and where do we stand as far as the HFNC is concerned. So this is a 32-week of 1.3 kg baby LSC is delivered The child was having a respiratory distress with SAS of 4. X-ray was suggestive of mild HMD, and child was otherwise hemodynamically stable. So what kind of a respiratory support will you start for this child? You can put your answers in the chat box. So one can start with the CPAP or HFNC. Let's see that what, sorry, sir.
Don't see any. Go ahead, please.
Yeah. So I don't think we even have a time for waiting for the answers. Yeah. So
Okay.
yeah. So let's look at the evidence regarding role of HFNC and CPAP as a primary support. And here in this forest chart, we can see that this favors the CPAP. The outcome favors the CPAP. But in this, if we look at the maximum number of patients were there in the Robertson and et al. Study, and this Robertson and et al. I'm not able to. So the major number of infants are there in the Robertson and study, and if we again look at the Robertson and study, this outcome favors the CPAP. But if we look at it in detail, more than 80% of the infants who were of more than 32-week gestation age were managed with HFNC alone. Though the primary outcome favors the CPAP, for those who are more than 32-week, HFNC can be considered as a good primary modality to start with the good primary respiratory modality to start with. Now let's look at the evidence of HFNC as a post-extubation failure. So HFNC has similar rates as the Cochrane analysis, similar rates of efficacy to other forms of non-invasive respiratory support in preterm infants for preventing treatment failure, death, and CLD. There's a small reduction rate of the pneumothorax and small reduction rate in the nasal trauma. But here the evidences, whatever are available, are mainly a use of HFNC as a post-extubation failure. So the HFNC can be used to prevent post-extubation failure. Like after extubation, you can put the child on HFNC then as a primary modality for those who are more than 32-week baby. Sometimes if you require to wean the child from the CPAP, at that time also you may put on the HFNC. And if there is too much of nasal trauma with the CPAP, one can try shifting to the HFNC, and it can also be used in the apnea of prematurity. But its use as a primary modality is still under vigorous clinical research, especially for the extreme premature babies who are less than 32 weeks. That should be the take-home message here. It is contraindicated if there is a frequent apnea, upper airway abnormality, severe hemodynamic instability. And how do we set HFNC? So while setting up the HFNC, you should consider the low of 5. So 5-3 for H3. Start with 5 liters of oxygen. Start with 50% of oxygen, 5 liters of oxygen, 5 liters of flow, and 50% of FiO2. And in this case, if you have started with HFNC with 50% FiO2 and 5 liters of flow, 2 hours later, if baby's need increases and if there is a need of FiO2 goes to 60%, and if child is otherwise hemodynamically stable, you can think about increasing the flow. So when do you increase the flow? When FiO2 need increases by 10%, if there's a worsening distress, if X-ray is showing that there is a less volume in the lungs, or if there is an increasing CO2, in that case, you can think about increasing the flow from 5 to 6, 7, and you can go up to the 8 liter. But the flow increase should be done 1 liter per minute. How do we wean the child from HFNC? Once the child is stabilized for 10 to 24 hours, then you should start weaning from the HFNC. In that case, wean the FiO2 first, reach up to 30%, then try weaning the flow 1 liter per minute every 12 hours. Then if you reach up to the flow of 3 liter per minute, then HFNC can be discontinued. When you consider to upgrade the support, when you consider that the HFNC is the failure, so if there is a persistent FiO2 need of more than 50% in spite of increasing the flow, if there's increased work of breathing, If there's a respiratory acidosis, pH being less than 7.25 or CO2 being more than 60, and if there's a recurrent apnea, if patient is on HFNC, at that time you can think about upgrading the support to either CPAP or NIM. So take-home message with the HFNC is, pressure generated with the HFNC is variable. You neither can set the pressure, nor can measure the pressures. Remember the rule of 5 while starting the HFNC, 50% FR to 5 liter of flow. And prong should occupy the less than 50% of the diameter of the nest. It should not be too big, otherwise you'll end up giving almost kind of a CPAP. It has proven role for post-extubation from mechanical ventilation, and its role as a primary modality is still under dilemma. And for extreme premature baby, it is to be avoided. Those who are more than 32 weeks, you can try HFNC as a primary modality if there is a mild to moderate respiratory distress. And it can be used as a weaning from the CPAP if it is required for prolonged durations. Here I'll end with the HFNC and I'll start with another talk that is is it being still shared, right? Screen is being still shared now?
Yes, it is being shared.
Yes. Seeing your screen and everyone is awake.
Yeah, hopefully. Okay. So, so then we'll be considering the second modality of non-invasive respiratory support, that is the nasal intermittent mandatory ventilations, NIMV. So this NIMV includes the variable pressures, and that includes BiPAP, NISPPV or NIPPV, and NHFOV. So we will be discussing all these three a little bit in detail in next probably 15 to 20 minutes if time permits. So first, let me touch upon the BiPAP. So what is BiPAP? It is kind of a CPAP where there are one level of the PWP, and top of that there is a second level of the PWP. So there are two levels of the PEEP. Here we can see that the second level of PEEP is also being set, but the delta P here is very less. Like second PEEP is, if you have set the PWP of 5, then the second level would be somewhere around 8 to 10. So the delta P here set is less. You can also set the I time, that is the required time for which you are going to give the higher level of the PWP. And patient can breathe at both, like lower level of PWP and higher level. You can see the spontaneous breathing even at lower and the higher level. So the I time here set is little bit longer compared to the routine mechanical ventilation. So longer I time, shorter delta P, and 2 level of the PWP. That is what your BiPAP, and this figure is of CPAP machines of Viasis. And here you can see that the expiratory limb is free, and the pressure generator device is somewhere near the nasal prong here. Here. The second is NIPPV, that is kind of a PWP and setting up of the PIP, so lower level and the higher level. And you can also set the rate, kind of a mechanical ventilation, which is given through the ET. Here you can give the mechanical ventilation through the nasal prong or nostrils. And third one is the HFOV. It's kind of giving a high frequency rates, that is the nasal HFOV. So these three are there. So let's look at the evidence that where we can use which modality. So this is a 26-week, 750-gram female child was intubated in the delivery room. Child received the surfactant and mechanical ventilation for 4 days. After that, the child was extubated to CPAP with the pressure of 5 NFI to a 40%. But unfortunately, 18 hours later, the child respiratory distress increased, and there were 3 episodes of apnea in 1 hour. The FR2 need has also gone up to 50%. PEEP was 5 and with PEEP was 6, and with that their sets dropped to 88%. ABG also worsened. So in these situations, what do we do next? Shall we again intubate the child and put on the ventilator, which we usually are doing? Shall we increase the PEEP to 7 and FR2 to 60%? Shall we start with the NIPPV, or is there any other option? So let's look at the evidence. So there are many evidence, but this is the latest network meta-analysis done by our own colleagues, Kiran and Veera and all those, and the study published from India itself. And this is a very large network analysis, which includes the 33 studies, 4,080 preterm neonates, and where they have just seen the efficacy of non-invasive respiratory support as a post-extubation respiratory failure. And there they have compared 7 non-invasive respiratory support modalities. And what they found is synchronized intermittent mandatory ventilations is considered to be the best, while continuous flow CPAP is considered to be the least effective modality for preventing the extubation failure in preterm neonates. Almost same authors, Veera, Kiran, and Shushma Madam, and another network meta-analysis published where they have compared the non-invasive respiratory support modalities, different modalities, as a primary support. And here they have compared high-flow nasal cannula, CPAP, BiPAP, and NIPPV. And their outcome was to decide the need of mechanical ventilation within 7 days. And they have included again 35 studies, 4,078 preterm neonates, and they checked for requirement of the mechanical ventilations. And what they found was NIPPV was more effective in decreasing the requirement of mechanical ventilation than the CPAP. Again, as far as the treatment failure was concerned, both NIPPV and BiPAP were more efficacious compared to CPAP and HFNC. Risk of leaks were less with the NIPPV. BPD and mortality was again lesser with the NIPPV, and nasal injury was less with the HFNC compared to the CPAP. That is what they found. So most effective primary mode for a non-invasive respiratory support in a preterm neonate with the RDS was, according to this study, was NIPPV. So with this analysis, we almost got agreed we should start with the NIPPV. In our case scenario also, we could have shifted the child on NIPPV rather than jump on intubating and putting on the mechanical ventilator after extubating the child. We could have extubated to NIPPV, but can we use the same ventilator on which the child was before? And the child was on the SLE 5000. So we can use SLE 5000 or the routine ventilator, but though it is not a synchronized NIPPV. So when you are delivering the NIPPV, the synchronization is important. Then only you will be able to deliver the effective NIPPV. So that's why the device which has been used to deliver the NIPPV is important. So now what is synchronization and how this synchronization happens? For synchronizations, you need to have a trigger sensors in your ventilator. So there are various varieties of the trigger sensors. One is the flow trigger, second is abdominal, third is NAVA, and fourth is the pressure one. The flow sensors are basically, they measure the flow, and depending on the change in the flow, the breaths are being detected and it is being triggered. The advantage is they can also measure the flow. Inspiratory tidal volume can also be measured, and it is most sensitive. But disadvantage is leak can affect the triggering, and again the main disadvantage is availability. The flow triggered non-invasive ventilators are very less, hardly 1 or 2. Then there is the abdominal sensors. This abdominal sensors again was there in the CPAP also. It's called the Gresby's capsules. It's kind of it is shown in the picture. It's kind of a rope kind of thing which you can stick on the abdomen. And as the patient starts spontaneous breathing, there will be a distension of the abdomen. With that, there is a compression of the capsules, and signals are being sensed and breaths are being detected. But it is very less sensitive, and this sensitivity also decreases with the abdominal distension. It also depends upon the site of placement. But advantages, it's inexpensive and it is very simple. The third is the NAVA, naturally assisted ventilation assist, where we just put a simple sensing catheter through the esophagus, which sends the electrical activity of diaphragm. But again, it's invasive, it is expensive, and it cannot measure the flow, though it is sensitive. The fourth one is the pressure sensors. So these pressure sensors detect the change in the pressure, and depending upon the change in the pressures, they detect the breaths and trigger the breaths. So as soon as a patient starts initiate the breath, there will be a decrease or drop on the pressure. And as soon as the prescribed pressure trigger threshold is being achieved, this breath is being detected, sensed by the ventilator, and the mechanical breath is being given. So that is how the pressure sensor works. But disadvantages, it is less sensitive. Change in the pressure is very minimal in case of the newborn. So auto triggering is also very high with this, and leak can also be affected by the sensing. It is inexpensive and sometimes no special ventilators are needed. And this is the ventilator which I use for giving the non-invasive. So I'm not promoting any brand. So here we can see that the white one is the non-triggered breath and the green one, the blue one is the triggered breath. So what I'm trying to show is as soon as there is a leak, if your sensing device is good, it won't be detected and it won't show the auto triggering. Here it is not showing on auto triggering even if there is a leak. Only when there was a breeze, at that time there was a blue breath which is being sensed and which is being triggered. So if you convince that the NIPPV is a good modality, then let's discuss that how do we set the NIPPV. When you are setting, again, the setting is almost similar. The PEEP should be of 6, PIP of 20, respiratory rate of 40. But here what you have to be careful is putting the I time. So I time should be little bit longer than the mechanical invasive ventilation. It is 0.5 seconds. Why? Because we have anatomical dead space here. There you have intubated and directly your ET is at the lung level, carina level. So I time we usually set is 3 times the time constant, that is somewhere around 0.35 to 0.4. But here we set the I time on higher side because we are on the non-invasive things. So that is 5 times the time constant, that is 0.5 seconds. So start with 20/6, 40 rates and 0.5 seconds. Sometimes in case of BPT, though I have not gone this high ever, but sometimes in case of BPT, you may require to go as high up to 30 to 38 of PIP and 10 of PWP. So how do we wean the patients from the NIPPV? So we start weaning, and once the FR2 is less than 0.4, pH is like settled, more than 7.25, and if CO2 is less than 60, at that time you may start weaning the child from an NIMV. First, you should start weaning the PIP, then PWP, and then respiratory. Come down on PIP from 20 to somewhere around less than 50. If your PIP is on 5, and then gradually coming down to the rate, and if you reach to the rate of 20, at that time you may start stopping the NIMV and can start thinking can shift the child on CPAP. So this was regarding the NISPPV or NIPPV. So now let's discuss something about the NHFOV. What is nasal high frequency ventilation and what are the evidence about its uses? So if we look at the literatures, this was the article published in 2017 where they have compared the NHFOV with CPAP following CPAP failures, and those were like those infants were less than 1250 grams, and this RCT has included 39 infants, and what they found was NHFOV was not superior to biphasic NCPAP in this pilot trial. Then there were further study. This is from the China, and this was probably published in 2021, which has included 244 preterm infants, again comparing the NHFOV versus BiPAP. And here they found that NHFOV was superior as far as the Ehrlich syndrome was concerned. It was lesser with the NHFOV. The severe BPT was significantly less, and the duration of hospitalization was significantly lesser with NHFOV compared to the BiPAP. Now, the mechanism of some of the authors have thought that the NHFOV could lead to the CO2 removal in better way, and that's why they just tried comparing that the CO2 removal. How is the CO2 removal with the NHFOV? Sorry. So they just had this was the article published from the Italy, and this study was done across the 8 centers in the Italy, which has included 30 preterm infants, those who were less than 1500 gram and less than 32 weaker, and they found that NHFOV delivered through the nasal prong is more effective than the CPAP in improving the elimination of CO2. So what we believe is if your child is otherwise not throwing apnea, is doing good on the CPAP, but there is a high CO2, and if you are not able to exhale the CO2 or PCO2 level is higher, at that time one may try with the NHFOV so that the CO2 removal could have been better with NHFOV compared to the CPAP. So how do we set? When you are setting an HFOV, the frequency should be low, that is 8 to 10 hertz compared to your conventional HFOV. I time should be longer and I ratio should be 1:2 to 1:1. And this is how your NHFOV is high frequency. So take home message here is, oh, I'm on time. NIPPV, this is a primary modality as well as after extubation for the preterm infant. Are you? It decreases the need of intubation, mechanical ventilation, and also BPD. SNIPPV is better and flow triggers are the best. Both NSIPPV and synchronized and non-synchronized NIPPV are better than the CPAP for extubation failure prevention, because there were a couple of studies where they have done even the group analysis, and in group analysis they found that synchronized is definitely best, but even non-synchronized ventilation is also better than the CPAP as far as the extubation failures are concerned. Nasal HFOV can be used in selected cases, but most studies are needed. Indication to put the tube has changed after introduction of NIPPV. So this was the take-home message here, and I thank you all. Thanks for patiently listening. If you have any query questions, we can take those queries and questions. Is there anything? Nothing.
Thank you, Biraj, for a very excellent talk. I think you covered everything in a short span of time. I'm not seeing any questions in the chat box. Just one thing which I would like to highlight is that everyone, whatever mode you are using, you should know your machine properly. That is the most important thing. Because all the machines have different ways to do. There are limitations of different machines and there are strengths of some machines. So you should know your machine properly. Whatever mode you want to use the BiPAP mode, or you want to do the synchronized NIMB, or you want to use the nasal HFO also. So now you have lots of different companies coming with different machines, and you should know your machine well. And I think we are still in a learning phase about nasal IMV. Gradually, we will get more and more studies. I am very much obsessed about nasal HFO also now, because there are a lot of good trials coming, which where nasal HFO has been used as a primary modality of treatment, comparing nasal HFO versus CPAP for primary RDS. Post-extubation settings, the results are quite good, but even in primary mode of ventilation, it can be used. And the synchronized NIMB, which all our ventilator machines can deliver, so it can be a good mode to start off with primary respiratory disorder also. So I think more and more evidence is coming, and we'll be very happy to see more and more trials and more newer guidelines coming for nasal IMB. Our target is very, very clear. We don't want to intubate.
Yes, that's what the indication for intubation is changed now.
Yes. We don't want to intubate. That is the main thing. Whatever you want to do, you use very high CPAP, you use BiPAP, you use the infant flow CPAP, you use the nasal HFO. Our target is very clear. If you are not putting the tube inside, then you are preventing a lot of complications. So I think, Jatin, any feedback, any comments from your side? Jatin, you are mute. You have to unmute yourself.
No, it was very clear and clear messages has been passed on by ma'am about recent evidence. No, ma'am, recent evidences are very clear, and whatever you told is absolutely super, and it was very short and brief, ma'am. It was excellent talk, ma'am.
Thank you.
Okay. So thank you, Biraj. Thank you very much for this excellent talk. And
I have a query. I have one query, sir.
Yeah.
I just want to ask both of yours protocol, yours and ma'am's, post extubation, whenever you are needing intubation, you might be using more of high frequency, and madam might be using more of maybe conventional ventilator. The post-extubation, what is your preferred mode for preterms, especially when you are needing preterm ventilation?
So
Okay,
if
see
it's
from
a-
our, yeah, Biraj
just
first.
so if it's extreme premature infants, we definitely would like to extubate them as early as possible. As soon as they are on little bit of, like okay support, even 30% of FiO2, we would like to extubate and put them on the non-invasive one.
So what is your preferred mode of non-invasive one?
NISPPD
NIMB.
or
Okay.
SN, non-NISPPD or SNIPP. Like I don't have SNI, I have a
You also don't have.
one. Yeah, in SLE.
Okay.
So basically, you are not putting them on CPAP, you are putting on the nasal IMB modes.
Nasal IMB.
Preterm babies post
Like
extubation.
26 weeker, if I'm extubating in within 2 days, so definitely in nasal IMB.
Okay, and if you are having frequent apneas on that, or if you are having CO2 retention, then what is your next
Then you
strategy?
have to
When do you
re-intubate, but definitely it is worth giving trial once. That's what I mean. Because if the patient is on 30% of FiO2, and if you have just put the child on the volume ventilation, where you can see that the pressure need is not too much, somewhere around 12 ka hi PIP ja raha hai, then what is the meaning on keeping this child continuously on the invasive one? So that was worth justifying giving a one extubation trial, putting them on the non-invasive ventilation, because still I know at 26 weeker, day 2, day 3 apnea બધું થવાનું જ છે. So better to put them on there. But yeah, on that also, if there is a recurrent apnea, then we need to intubate again.
Fine, fair, very correct. And I think in
Yes.
our unit, what we do is basically, if the baby is on conventional ventilator, we extubate to CPAP only. We have used the BiPAP mode many times with frequent, a little bit of few breaths, 8 to 10 breaths, just to take care of the apneas, what we see. But I will not say it works very great. We have tried nasal HFO for a lot of preterm babies, and it works quite well. For babies who are having significant apneas, with the X-ray remaining quite good, when the pulmonary compliance is good, then in those babies, I think nasal HFO works quite well because it helps in CO2 washout. It is stimulating the child to breathe a little bit. It might be stimulating the respiratory centers also, the receptors in the nasopharynx, oropharynx. So nasal HFO does work. But for preterm babies, from conventional, we go to CPAP. For HFO, we go to nasal HFO.
That CPAP you give through the ventilator only, or bubble CPAP you use?
No, we use the infant flow CPAP, so we shift to infant flow CPAP only.
Okay, you change the
So
machine.
Nasal HFO are you using? Which device are you using to give the
We use the sensor medics only.
same one with the only
We use the sensor medics with the RAMS cannula.
Okay.
We almost put them on the same mean airway pressure, and then we try reducing the amplitude, and once the X-ray and everything is okay, the breathing efforts of okay, then we shift them from the nasal HFO to the high flow nasal cannula.
Okay. So Wiggle might not be visible, right, sir? With RAMS cannula, with sensor medics.
Wiggle will not be visible also. It may not be audible also. But I think what we have seen is that the number of apneas are quite less on the nasal HFO mode. Second thing, the CO2 remains in a better range. On the CPAP or on the other modes, when the CO2s are in the range of 55, 60, here the CO2s remain in the range of 40 somewhere. So I think it is relatively okay to us, but still we do not have a lot of trials to prove that. But we are, I am getting all my data about nasal HFO also. So it is working. We are not using it as the primary mode at this point of time, but I'm quite convinced with the way we can recruit lungs even on the nasal HFO. So if you want to put the patient on CPAP, that is what standard, what we all do on the non-invasive mode. If the baby is not improving on CPAP, then what do we do? We will have to land up into intubation. But what we do is that if the baby does not improve on CPAP, then we try put him on nasal HFO, try recruiting the lungs on the nasal HFO, which we do not get on the conventional CPAP. We may go till 7, 7.5, 8, but we don't go more than 7.5, 8 most of the times. And with that, FiO2 more than 50% after surfactant not improving, then I think nasal HFO is one mode which we can try before intubation.
In conventional sensor,
that is what was there in the study which I published from the Italy, which I mentioned from the Italy. Yeah, so that
what I have seen is that about experience about HFO and nasal HFO, every unit has a little bit of bias. if you see Dr. Van Camp's unit, then they have very good articles. They have very good experiences with early HFO. And if you see some centers which are more fond of volume control ventilation, they have very good results with volume control ventilation. So I always say that do whatever you know best and continue doing that. If I may be doing
Sometimes it
HFO
is
well and
individualized too, like back to back, I had a 2 preemies where, like, you know, putting them and shifting them on volume was really difficult. I just extubated them from a high frequency only. I went into high frequency up to the 6 map and then I extubated directly. So sometimes it
we are
happens.
never shifting to conventional. From a HFO, we directly extubate even maybe a preterm child or a full term. We extubate directly from HFO. For preterm babies, we may put them on high flow, or because we don't put them on CPAP, because HFO is basically CPAP only. So if I'm extubating the child, then I'm just putting him, I'm just removing that mean airway pressure is minimum, not maintaining. Then we'll put them on high flow, or then we can directly extubate. We are not using the conventional after HFO, but every unit has a different way to do it. So whatever I am comfortable, my unit is comfortable, everyone will not do the same. But we have evidences in favor of that you may extubate directly to, without going for the conventional, you can directly extubate them to either the non-invasive modes or directly through oxygen.
Thank you.
Okay, it was nice.
I think we'll wrap up with the final note that learn ventilation as an art, and master your art, and then try doing that in your unit. Train your team for that thing. Maybe conventional ventilator, high frequency, whatever modes of non-invasive, what you are trying. There's a good amount of evidence that everything works basically until you are doing damage to the child. So that, as I told in my talk, that first do not do any harm to the child. And I think all these modes are basically only to do minimum damage to the child. So thank you, Biraj, for an excellent talk. And I think we will end up the session today, all the delegates, and thank you for being a part of the program. And I want every one of you to be tomorrow in time at Anand Hospital. I have shared the address also on the group, and see you all tomorrow. Thank you. Good night.
See you day
Thank
after
you.
tomorrow.
Good
Bye-bye.
Bye.
Bye.